4 panels today, and what I'd like to ask the panels when they come up is, everybody has given us some written testimony, and if you are so inclined to maybe not read that word for word and maybe kind of talk to us, we'd like to have a back and forth conversation. What's important to me today is that the members of this committee understand what we're talking about when we're talking about parity, and getting the message out that basically our insurers are not covering mental health and addiction the way they do other issues. So as you guys all know, and we all support here today, we're talking about the care of our brains. So we need to make sure that people start to understand that our insurance companies need to start caring for our brains the same way they do for the rest of us. So the first panel will be David Lloyd, who is the policy director for the Kennedy Forum, Matthew Timon, who is a father and a mental health advocate, William Cordy, who is a mental health advocate, and Tim Clement, a senior policy advisor for the Kennedy Forum. If you can come forward and state your names before you speak.
Ready? Good morning, Chairwoman Conroy and members of the Committee on Mental Health. Thank you for the opportunity to testify at today's hearing on mental health and addiction coverage. My name is David Lloyd. I'm Director of Policy and Programs at the Kennedy Forum, Illinois. Our mission is to end stigma and discrimination against those with mental health and substance use disorders. So next year will actually be the 10th anniversary of the Mental Health Parity and Addiction Equity Act, which was signed into law by President Bush in 2008. And as many of you know, this landmark law offers broad protections to millions of Illinoisans that their health plans offer mental health and addiction coverage on par with coverage for other types of medical conditions. And Illinois has actually followed the federal government's lead, both incorporating the Federal Parity Act into the state law and making it even stronger. However, without effective enforcement, our state and federal parity laws are too often an unfulfilled promise, and barriers to coverage stand in the way of people getting the mental health and addiction treatment they need. And for years, in Illinois, we've had anecdotal reports from individuals and providers about the difficulties they have in getting mental health and addiction coverage, but these were just anecdotes. So therefore, the Kennedy Forum and our provider partners and associations put together a survey of providers on their coverage experiences. And in the results, providers reported encountering frequent barriers from both Medicaid MCOs and commercial insurers to treatment coverage. These results raise important red flags that need to be investigated further to both identify and eliminate these coverage barriers and to ensure that health plans are in compliance with the federal parity laws and state parity laws. While I present a full range of survey results in my written testimony, here are just a few samples of what providers reported. First, over 80% of responding providers reported that Medicaid MCOs sometimes, often, or always decided that requested acute mental health and addiction treatment was not medically necessary, and over half of responding providers said the same of commercial payers. More than 6 in 10 responding providers were often or always told that Medicaid MCO networks were simply closed, while nearly half of providers were often or always told the same by commercial payers, and 9 in 10 responding providers reported that health plans have refused to provide requested medical necessity criteria as required by the law. This survey is supported by report after report that comes to the same conclusion, that mental health and addiction care is not being offered on par with coverage for other types of medical conditions. In fact, an important report released just last week by the independent actuarial and research firm Milliman found significant disparities nationally and in Illinois between mental health and addiction coverage and coverage of other medical conditions. For example, the data it analyzed showed that in Illinois, out-of-network usage was higher for mental health and addiction care than for physical care by the following factors in 2015. For outpatient facilities, out-of-network usage was 2.5 times higher. For inpatient facilities, it was 1.8 times higher. This report, which reviewed never-before analyzed actual claims data, strongly suggests that in-network care was inadequate when compared to in-network medical care, raising urgent questions about whether insurers are complying with parity laws. So what must be done? First of all, we should focus on what should not be done. We should not place the responsibility of enforcement of parity laws on consumers and providers. Consumers and providers dealing with crisis situations are not well placed to enforce the law, both because they are not in a good position to know all the law's requirements, and because more fundamentally, they do not have the necessary information to conduct a comparison between how plans cover mental health and addiction care and how they cover medical care. Indeed, these very issues are why the Illinois General Assembly amended the state parity law in 2015 as part of the Heroin Crisis Act to add the following language. The Department of Insurance shall enforce the requirements of state and federal parity law, which includes ensuring compliance by individual and group policies, detecting violations of law by individual and group policies, proactively monitoring discriminatory practices. The word proactively is particularly instructive. Its plain English definition, quote, by taking action to control a situation rather than just responding to it after it has happened, makes clear that the Department of Insurance has a responsibility under Illinois law to enforce parity laws without sitting back and waiting for complaints. Because parity laws are all about comparing mental health and addiction coverage to medical coverage, health plans and regulators must do detailed comparisons to ensure that plans are in compliance. Without a comparison, there is simply no possible way to know whether parity laws are being complied with. It is particularly essential for plans and regulators to conduct detailed comparative analyses of non-quantitative treatment limitations, often abbreviated NQTLs, in place on mental health and addiction care versus those in place on medical care. In fact, health plans are already required under federal law to conduct detailed analyses of their non-quantitative treatment limitations, which are any limitations that are not numerically expressed. An example are prior authorization requirements. The Kennedy Forum and other leading national organizations are working with health plans and federal and state regulators to ensure that plan analyses demonstrate compliance with parity laws. In my written testimony, I go into detail about what Illinois should be doing, and Tim Clement from the National Kennedy Forum and Sam Ruzinski of the American Psychiatric Association will testify shortly about best practices of parity compliance from across the country. Suffice it to say, both the Department of Insurance and Department of Healthcare and Family Services need to ask for plans analyses that they are already required to do under federal law, verify these analyses prior to plans being offered to make sure that they in fact demonstrate compliance, verify that plans' actual practices are in compliance with the law through regular targeted examinations. Lawmakers also have a critical role to play in improving parity compliance by both holding regulators accountable and passing legislation such as Representative Lang's House Bill 68, which would improve transparency and increase accountability on parity law compliance. In conclusion, parity laws are all about fairness and ending discrimination and coverage against people who happen to have illnesses of the brain. To effectively combat our ongoing mental health and addiction crises, we must make parity compliance a priority. If we don't, too many families will be unable to access treatment, with the resulting higher costs representing a cost shift from health plans to taxpayers. Thank you for the opportunity to testify. I'm happy to answer any questions you might have.
Okay, maybe we can finish the panel and then do questions, if that's okay.
Good morning. My name is Matthew Timian. I live in Moline, Illinois. I am a father and a reluctant advocate of mental health. It wasn't a choice. Forced upon me. I adopted my son when he was 3 years old out of the foster care system. And, you know, adoptive kids, they often warn us about the potential problems that they might have. Everything looked great, though. We moved to Illinois approximately 5 years ago from out of state. We were in Utah at the time. And due to a number of circumstances, his in-state Medicaid did not transfer to Illinois. So as a result, his medical insurance was through my private insurance through work. Now, his behavior as he aged became increasingly alarming. We had instances of self-harm, suicide attempts, audiovisual hallucinations, poor impulse control, fire starting, a slew of problems. And his diagnosis over the years has ranged from ADHD, bipolar disorder, PTSD, fetal alcohol syndrome, reactive attachment disorder, and borderline personality disorder. It's really hard to peg down exactly what's going on in a kid's head, but all the professionals involved have agreed that he needed an extra level of help, and that's where my private insurance came in. Now, for 3 years, he saw a private therapist through my insurance twice a week. He saw a medication manager once every quarter or so, and he had a social worker at school, and he had a slew of professionals surrounding him. A number of incidents occurred. He had been in inpatient hospitalization, I think at this point, 6 times. So this is usually precipitated by self-harm or homicidal threats, things like that. So he's had this long history, and his therapist, his medication manager, school professionals, and the psychiatric in resident at the inpatient psychiatric hospital all agree that he needed a higher level of care than we could provide. And this isn't to say he needed to be locked away. It was to say what we were doing was not good enough, and he needed better intervention. And so we started a plan, and we needed to find a residential facility. Now, luckily for us, there was one locally that had just begun taking our health insurance, and they accepted him. And there is an understanding that residential facilities have about a 12-month treatment program, and you need to complete the entire program. It's part of how it works. And they also, when you go in, they let you know that the first month is going to be a honeymoon phase where the resident will not act up. They're going to comply with medication. They're going to follow the rules because they think if they're good, they can leave. And so everyone knowing this going in, the health insurance required us to have a weekly call to justify the expense of the residential facility. So there were a lot of hoops that we had to jump through. And because my son was on his honeymoon phase, he had just, he was acting his best part, the insurance company decided after 4 weeks that he no longer required this level of care. So this is ignoring the advice and, the conclusion of many, many mental health professionals over the years. Private insurance said no. And so I was given a 48-hour notice to pick up my son and bring him home, which was not an option because of safety concerns. On the very day that the health insurance quit paying, my son attacked another resident at the facility, and then my son ended up back in another psychiatric hospital for 2 weeks. This is the kind of thing that happens regularly. It's happened during inpatient stays at residential and at psychiatric hospitals. There have been a number of times when safety was an issue at home. He had just threatened me with a knife, and a week later, without any remorse, without any sorrow on his, I didn't feel like there was any resolution to this. I was told that he was ready to come home, which was dictated more by the insurance company than the hospital or the professionals. And so what ends up happening in these cases is I don't pick him up from the hospital. He stays longer than insurance will provide, and ultimately the state picks up the bill. And we've been through the process where we fight, we contest it with the insurance company, and after a lengthy appeals process, in one case we have won, but in other cases we don't even bother and the state picks up the tab. And so it's my experience and the experience of other parents I've talked to with similar situations that insurance is treating these children and more broadly mental illness as like a broken bone. They're putting a cast on it, they're giving you some medication, and they're sending you out the door. And they're not treating it like the chronic illness that it is. In my son's case, it's likely due to early childhood trauma, in utero exposure, any number of things that happened before he came into the home. But it's still there, and it still needs to be covered. And the impression has always been that they're pushing them out the door as soon as possible, going for the less costly alternative to treatment, instead of actually finding what will work and what will prevent the long-term problem. And thank you.
Matt, how old is your son currently?
He is currently 14.
Okay, thank you. Also, I'd like to add Representative Feigenholz to the roll.
Good morning. Thank you for the opportunity to speak today. My name is William Cordy. I live in Evanston, and I'm a project manager at the Institute for Policy and Civic Engagement at the University of Illinois at Chicago. I'm a member of NAMI Chicago, part of America's largest grassroots mental health organization, the National Alliance on Mental Illness. I have bipolar disorder, and I have seen firsthand how the broken healthcare system and Medicaid perpetuate silos and exclusivity, where only certain patients or individuals are able to access the best care available and the treatment that they need. My experience have consisted of being under the worst duress, suicidal ideation, psychosis, and manic states, but not being able to see a psychiatrist in a timely manner because there were waiting times of 4 to 6 weeks to see one. I have been denied access to intensive outpatient programs and inpatient psychiatric programs simply because I had Medicaid. I have experienced being sent to a state hospital in the most humiliating circumstances, tied to a gurney, even though I was clearly not in the proper state to be transported, and even though the nonprofit hospital where I had been admitted to had a room and a bed for me. I have mistaken my meds on time simply because I wasn't permitted to get in touch with my psychiatrist for a refill authorization. The main thing that has helped me during my recovery is knowing that I am not the only one who has experienced what I have experienced. Being able to volunteer with NAMI and speak to high school students about stigma and share my personal story of recovery has liberated me. Attending support groups and speaking in public have made me feel empowered and provided me with the knowledge and vigor to sustain my recovery. It has helped me feel like I wasn't just a docket number or a file. Feeling that my story matters is something that I can share with anyone, and that the hardships I've had with Medicaid and in all of my experiences haven't defined my recovery. I have been able to overcome them. Despite these obstacles, I have managed to find my niche. I am able to find what works for me, and I feel that there are places where I can go and people who I can talk to when I need support and treatment. I no longer feel alone or vulnerable or abandoned. Everyone should have options and access when it comes to mental health providers, especially in a timely manner, and being able to choose the best programs and the best providers out there and that meet their needs. When people are precluded from programs and seeing doctors because of their insurance, it creates an unequal system, a separate system, and separate is never equal. Based on my experience, I think we must create a system where people can have access to all mental health providers, including hospitals, clinics, outpatient and inpatient programs, and physicians when they need them. Thank you so much for listening to my story today. I appreciate your time and consideration. Thank you.
Good morning. Thank you for having me to speak here. My name is Tim Clement. I'm the Senior Policy Advisor for the Kennedy Forum, the National Kennedy Forum organization, which is led by former Congressman Patrick Kennedy, who is the lead sponsor of the Mental Health Parity and Addiction Equity Act. I also run a project called the Parity Track Project, which tracks parity implementation in all 50 states. So I have analyzed legislation, regulatory actions, and state code relevant to mental health and substance use disorder coverage in every state state. I would like to congratulate the General Assembly here in Illinois, because you guys actually, the state of Illinois actually has the strongest mental health and addiction insurance coverage laws in the country. It's better than any other state. That's the good news. The bad news is that there's been a lag in terms of implementation on the regulatory side of things by the administration. What I'm going to talk to you today, and I'm not going to go on for too long. I'm just going to explain a little bit more about what David talked about in terms of the difficult areas that we have, because I don't want to blast the insurance industry too much, because they have done a good job on several areas. I'm going to give you a few best practices from around the country, and I'm also going to talk about, very briefly, a tool that I've created along with Sam Uzinski from the American Psychiatric Association that the Department of Insurance could use right now. We could train them on how to use it free of charge, but they have been reluctant to get that training and use that tool. So just to talk a little bit more about the non-quantitative treatment limitations that David, because I know that when we kicked this meeting off, we said let's try to have a conversation about this, because I know that some of this terminology is incredibly complex. When I say non-quantitative treatment limitations, or NQTLs, I say to myself, I wish I never had to say that term again, because it's so confusing sounding. What we're really talking about when we talk about non-quantitative treatment limitations, and let me just back up. The insurance industry has done a very good job of coming into compliance with Parity when it comes to things like financial requirements, like co-insurance or co-payments, quantitative treatment limitations, like inpatient day limits, outpatient visit limits. It used to be, throughout the history of health insurance coverage in America, that insurers were very restrictive when it came to those things. Co-pays would be much higher. There would be these very restrictive visit limits. Illinois used to have some restrictive limits in place. Those things are mostly gone. The insurance industry did away with those things, and I give them credit for doing that, and they did it pretty quickly. The thing where they have not come into compliance are those non-quantitative treatment limitations, which is really a complicated way of saying managed care practices. That's how they design and apply their medical management techniques. Things like prior authorization or fail first requirements, or how they set reimbursement rates, or how they determine whether or not providers can participate in their networks. I'm going to do you guys a great disservice. I'm going to read to you the language from the federal laws, final regulations about these non-quantitative treatment limitations. Because one thing that David mentioned is that we can't rely on consumer complaints to determine if we have non-compliance with this law. I mean, this is going to, I hope, accentuate why that is. So this is one single sentence, and this is the most important sentence when it comes to parity. This is from the final regulations. This is 45 CFR 146.136, subparagraph C4, non-quantitative treatment limitations, general rule. A group health plan or health insurance coverage may not impose a non-quantitative treatment limitation with respect to mental health or substance use disorder benefits in any classification unless under the terms of the plan or health insurance coverage as written in operation, any processes, strategies, evidential standards, or other factors used in applying the non-quantitative treatment limitation to mental health or substance use disorder benefits in the classification are comparable to and applied no more stringently than the processes, strategies, evidential standards, or other factors used in applying the limitation with respect to medical surgical benefits in the classification.
I can only assume you don't expect us to have retained what you just said.
So what I would say is that if there's anyone in this room that understands what I just said, I would recommend that you receive a MacArthur Genius Grant, because that's impossible. I read that sentence at least 200 times before I finally understood it. I mean, that might be the most complex sentence in all of the earth. So requiring an individual who might be in the depths of a mental health crisis, or their family, to understand what that means, and if their insurance coverage is complying with that, I mean, that's not fair. I mean, that's like asking consumers to determine what the lead content is in their water. We don't do that. That's something that the Illinois Department of Insurance is required, as you required them to do 2 years ago, and they won't do it. I mean, I'm sorry if I'm being harsh on them, but they have not. We have given them overture after overture to come in and train them as to how it is that could be. They could, to check plans for compliance with that very complicated sentence, which is replicated in Illinois state law in 215 ILCS 370C.1. And the reason we need to check with that is because from around the country, when regulators have looked into that issue, like the New York State Attorney General's Office or California's Department of Managed Health Care or the Montana Department of Insurance, when they've looked into that sentence, determining if there's compliance with that sentence, they have found, there's big problems across the board. Whenever you look into it, they always find that there's a problem. And the biggest problem we find, and one of the things that I'll read just very briefly from that sentence again, it says, as written and in operation. That's a very important distinction, as written in operation. You can look at all the insurance plan documents in the world, and you can maybe determine if there's an as-written violation or not. But there's no way to know about an in-operation violation. So what Matthew was just talking about with his son, when the insurance company does that review to determine if care is still medically necessary, how are they doing that? And the law says that has to be done in a way that is comparable to and applied no more stringently than how they do so for other medical care. So how are they making that decision relative to how are they doing it for, say, muscular dystrophy or leukemia or other types of childhood diseases that when you're sick and your doctors say you need continued treatment, rubber stamp, it's approved. Rubber stamp, it's approved. Rubber stamp, it's approved. Because they know if they don't, they end up on 60 Minutes. So I think that, that's the thing I would emphasize. And also, I want to make clear, the insurance industry, there's not some smoke-filled back room where they're saying, gentlemen, how can we best discriminate against people with mental illness? Violate the law. They don't do that. It's a very complicated law, and that's part of the problem, but it is the law, and it's been the law for almost a decade. And we think that from what we've seen, when insurers sit down with us and with regulators and go through these very complicated issues, they realize, I guess we are doing that a little bit more restrictively, and they change it. But they do it in a very one-off fashion, and that's why you need proactive enforcement by the Department of Insurance, which has $1.4 million of federal grant money that they're supposed to be using to do this enforcement work. You need them to go and sit down with the insurers and ask them to demonstrate how it is that they're complying with that very complicated sentence. And everyone in the world, including the industry, would say, yeah, we're having some trouble with that complicated sentence, and they say they don't have enough guidance from the federal government. I would disagree. I think they do have enough guidance. And look, we have a tool that they could use, and it would put the burden of compliance on the insurers, not the Department of Insurance. They wouldn't have to do some sort of complicated review. They give the insurers the tool that we've created, and they use that tool, they fill out that tool, and they give it back to the department. They have to do the analyses as required already under federal law. We just give them specificity. It would be great if the Department of Insurance used that tool just to get ahead of the curve and make sure that, we find violations in every state that's looked into this complicated sentence. When they've looked into it, they find violations. Why would it be any different here in the state of Illinois? And just the last point about relying on consumer complaints, a survey by the American Psychological Association found that only 4% of Americans knew about the concept of parity. So if you're waiting for 4% of the population to talk about the 100% that might have problems, that's not likely. So I just couldn't stress more that there needs to be proactive oversight as specified by the legislation back in 2015. So I'll wrap it up there and I'll take any questions. Thank you.
So what you're saying is that there's no will federally to make that simpler or easier to follow. So we are now in a situation where state by state, now that people are finally realizing what parity is and what that means, that we now have to do that. We have to fight that battle or educate our insurance companies or work with our insurance companies. And I have no trouble bashing insurance companies. I will do that. So you're saying that falls on us now as a state?
Yes, that's correct. It's, that's the nature of the federal law, and this is what makes, as a wise man recently said, I think this year, that nobody knew healthcare could be so complicated. But it is, and it relies on both federal enforcement, and the federal agencies are doing a better job of enforcement, but then the state agencies, and it's up to the states to determine how it is that actual enforcement is, what's it going to look like. And that's one thing the insurance industry, they complain about, that we don't have to do it 50 different ways. That's why we created the tool that we created, and we're working with states like New York, Pennsylvania, Maryland, Minnesota, North Carolina to use that tool so that they'll do it the same way. But yes, that is correct. It's up to the state right now.
Okay, Representative Feigenholz.
Thank you for being here. You have the farthest drive award, I think, today. This is something that's fascinating, probably to me and everybody else in this committee, is that the laws are on the books. Federally and in Illinois, we have the strongest parity law. And you saw our report, which is better than most, but really not that good, right? I mean, you know, we're in the midst, last week there was a hearing. The state has this mega Medicaid lawsuit for children living with mental illness, the NB lawsuit settlement, which could be the mother of all consent decrees. But I'm just wondering if you have seen any success in any state where there's been pushback, and has it been through policy, regulation, or litigation?
So, yes, we have. We've seen success for sure in New York. It went through the Attorney General's office because their insurance department just simply refused to do their job. They're now starting to do their job. That's thanks to them hiring me and Sam to work with them. It worked. It worked for those 7 or 8 health plans that they came to settlements with in 2014, 15, 16, and even earlier this year. Isolated health plans for those health plans in the state of New York, things have gotten a lot better. California, it's worked there. They required insurers to submit all kinds of data related to that complicated sentence, and they're coming into settlements with a lot of those health plans now. It's taking them a long time because they unfortunately ask for too much information. That's what we need to make sure. When you ask for insurers, ask them to give you information, it's got to be targeted and laser focused. Don't ask for a data dump because they'll give it to you. They'll overwhelm you with information. But that's the solution, is the regulatory solution. And I mean, there's not too much more you guys can do in the General Assembly. I mean, you have done everything in the world related to this on the policy, the legislation side. You could mandate that the Department of Insurance do request the data in the way that our tool requires. The state of Tennessee did that earlier this year. There's a number of other states that are working to do that legislatively.
Well, that has been the reason I believe that some of the data is a little muddled, because we never specifically instructed the Department of Insurance to actually collect data on complaints. So when a consumer calls in, has a problem, the department doesn't record it, and we therefore have no data on that. But I think that we're a little beyond that. I mean, that sounds pretty boring to me, actually. So I'm very, very curious to know, maybe, and I'll talk to David about this, the success that you've been having in New York. Has it been litigated by the Attorney General, or has the Attorney General basically called in the insurance companies?
They came to direct settlements with them. I mean, they didn't actually go through formal litigation. I would warn against any kind of, there's a lot of litigation out there right now related to mental health and addiction insurance coverage. However, they're not generally going through the Parity law, because that's hard to do. And so unfortunately, it's a little disappointing. Some of the attorneys out there that have been working on this issue, they tend to take the easy way out, which I don't blame them, because they do have the responsibility to get their litigants, their cases settled. But
I have a follow-up question. Is the reason that New York didn't go through Parity because they haven't codified it like we did?
No, so New York, the Attorney General, they certainly did go through Parity. They have a state law called Timothy's Law, which is somewhat similar to Illinois state law, somewhat similar to the federal law, and they did go through the federal avenue as well. What they did is they worked with each health plan, and rather than taking them to court, they came to settlements, usually involving some 6 or 7 figure settlement agreement, and then a corrective action plan. So a lot of these settlements, while they reached them several years ago, they're still working with the insurers to make sure that they're doing what they were required within that corrective action agreement. So that's something that you would absolutely need any action, whether it's through the Attorney General's office or through the Department of Insurance. The Department of Insurance in New York could have done the same thing the AG's office did. They just didn't do it. But you need to have a settlement and then continuing corrective action.
Thank you.
So can you tell me, in your opinion, when we know that in our country and in our states we are in a crisis right now, why is there no federal will to simplify this and fix this? And why therefore are we being put state by state in a situation where all 50 states have to finally have the light go on to understand what parity means in the first place when people are dying in the streets?
Yeah, that's a good question. And tomorrow, Patrick Kennedy's going to be testifying in front of the Senate Appropriations Committee asking that same question. I don't want to be too political here, but I think you might want to look at the landscape in Washington, D.C., and who's in the Oval Office and who controls Congress as to why, for some reason, when nearly 300 Americans are dying each day from drug overdoses and suicides, we decide that we need to save multinational corporations their corporate tax rates rather than doing something to address the crisis. So, and again, I don't want to get too politicized about this, but there's not a political will, because I think that, we haven't been demanding that quite as stridently as I think we should. But I think you're right. We absolutely need a much stronger federal response. I mean, for instance, in 1996, when over 50,000 Americans were dying every day, or dying each year of HIV and AIDS, federal government doubled federal spending. They doubled federal spending in less than 10 years. The death rate plummeted. That's what we need from our federal government. Unfortunately, in this climate, we're not going to get that. In fact, we're going to see cuts, probably. But it does, some of the responsibility always will have to fall on the states because of the complex nature of health insurance, because of the Public Health Service Act, which is where the federal parity law is found as it relates to small group and individual insurance. That is generally the authority of a state to enforce that. The federal government could intervene, which they have done in several states that refuse to or cannot enforce the law, but in a state that does believe it can enforce the law, like Illinois has, they took the federal grant money. It is their responsibility for enforcement in the individual and small group and some in the large group market. So, but I do agree with you. We do need a much stronger federal response.
Thank you. Those things are so important to be said. I know it's not always easy to say them, but people need to hear it. Representative Fine.
Thank you. Why hasn't the department taken you up on the training?
I can't speak directly for the department, but we have reviewed the tool. It's a 6-step compliance guide that the Kennedy Forum and APA has put together that we think will actually, in a very systematic way, go through that paragraph and kind of step by step, show what compliance, how to actually achieve compliance. I think that since there is complexity, and we continue to hope that we can work with the department to utilize both this tool and to be trained on the tool, and also Parity more generally, to understand how as a state we can move forward together. Because certainly I think that the paragraph that Tim read is quite, is complex in how it's written, but at the very basic, at a very basic level, it is a not terribly complicated paragraph in that it just requires a comparison on these non-quantitative treatment limitations between the mental health and addiction side and the medical surgical side, and that's there's some fancy language about how that has to be shown, but at heart, that's what it's all about, and that's what the compliance guide that we've developed is all about.
If I could just quickly add, yes, I agree, and I think that it's a very overwhelming sentence, and I could see how a state regulator might feel overwhelmed and say, how am I going to figure that out? The good thing about our guide is it requires the health plans to demonstrate how it is that they are complying with that very complicated sentence in a stepwise process, so it puts the burden on them. So that's why I think it's, we'd really love to see them use that tool and get a training on it. So,
and you said they received a $1.4 million grant to learn to use the tool. Does that $1.4 million cover the cost of the education? And if they're not using the money for this, what is happening with the money? So
the $1.4 million is for a lot of things related. So the grant that they got was for implementing the Affordable Care Act, certain provisions, including Parity. We're not sure exactly what percentage of the grant. I probably shouldn't. We know specifically in their grant, because we reviewed it very carefully before they sent it along to the federal government, that it specifically said that they would do something like using this tool, very specific language in their grant, and you can review that on CMS's webpage. They said they would do what we've suggested they should do. And I think that the training that we're offering, they don't even have to use that money. We'll do it. Sam and I will come out here. I love Chicago, and I love the state of Illinois. We'll do it for free. We'll go there to, we'll give them a 4 to 6 hour training. We'll do follow-up, phone calls, webinars. They don't even need to use that money. We'll provide them that training.
And if they did have this training, what would be the result of it? How would it help people?
What it would do is it would require the insurers to submit their analyses of how it is that they're complying with that very complicated sentence, and not for every non-quantitative treatment limitation in the world. We just pick a few, like prior authorization, concurrent review, how they design their medical necessity criteria, and maybe take 3 of those complicated things and ask them to submit the analysis for how they have determined that they are in compliance both as written and in operation with the law. And then we would help the department review that information, and we would certainly work, off the record with the insurers to help them fill it out. We would give them training as they needed as well, because our goal is not to bring the insurers in front of the public and shame them. We just want them to comply with the law, and we want to help them in any way we can to have them do that.
And there's no penalty for noncompliance?
There doesn't have to be. I mean, if you don't get it right the first time, I think the goal of the department should be work with them to get it right. Work with them to design and apply their benefits in a non-discriminatory way. I think at the end of the day, everyone does want to do that. They're not clear on how they can do that, but I think this tool would really help them do that.
Thank you.
Representative Lang.
Thank you, Madam Chairperson. First, to Mr. Timian and Mr. Cordy, thank you for being here with us. Your stories are important, but I want you to know that while this may not have filtered down to your knowledge, General Assembly's actually been working on parity laws for many years. I have sponsored, and my colleagues have voted for many bills to strengthen our parity laws. Mr. Clement referred to the most recent one, which was House Bill 1 2 years ago, which was a large bill dealing with many issues. Started out talking about dealing with the opioid crisis. Now I see the governor's got a task force running around the state reinventing the wheel and work we've already done. But within that bill, as Mr. Clement said, we have the strongest parity laws now in the country. But yet, even with those strongest parity laws in the country, there's a big gap between the law and the practice, between the law and how it filters down to someone who has barriers between themselves and the treatment they need for themselves or their child. And so in that light, I have a couple of questions for Mr. Lloyd, but maybe Mr. Clement we can jump in as well. I know that many feel, I at the top of the list, that state agencies have been dragging their heels on the implementation of everything in House Bill 1. Remember, this is a bill the governor vetoed. And those sitting in this committee all voted to override that veto. So first, Mr. Lloyd, do you feel there's heel dragging? And let's go specifically to the issue of parity. And let's get that question answered first. Do you feel that the department is or is not implementing what they were supposed to implement under that law?
It's our opinion that we think that they certainly can and should be going more quickly than they are.
Have they met the guideposts that are in that law?
In terms of the parity sections of HB 1, the Heroin Crisis Act, many of the requirements are, are they kind of they have responsibility to enforce the statute. We do not believe that is currently being done like it can and should be done. So my answer would be that no, we do not feel that they are that the Department of Insurance is where it needs to be in terms of implementing HB 1. I will say that nationally there are very few insurance departments that are doing what they should be doing. So Illinois certainly is no exception.
Illinois is no exception. However, many of those other states are relying on federal law. Yep. We have our own state law that our own Department of Insurance is not implementing. Is that, Mr. Clement, would you agree with that?
Yeah, I would agree in the sense that while many other states are not where they need to be, no other state has had its legislature, like the General Assembly here, make this such a priority. Illinois has prioritized this front line more so than any other state in this country, but as you've said, there's a drag when it comes. I do think that they're dragging their feet, and I think that you've given them so much of what they need to do, yet they're not keeping pace with you guys, which I think is a bit of a shame.
And so let me dig a little further. Mr. Lloyd, I know that you have been at several meetings with the Department of Insurance on this issue. I was made aware of one particular meeting where it appeared that the bureaucrats in the Department of Insurance didn't even know what the heck mental health parity was, or what it meant, or how to describe it, or what to do about it, or how to implement the law. Would you agree with that?
Certainly, I think that there is a steep learning curve for insurance departments across the country, and we're eager to work with the Department of Insurance to make sure that all of their relevant staff have the information they need about what the parity requirements are, and certainly, we think that there's a way to go in terms of making sure that everyone who needs to be trained on parity, is trained on parity and understands all the aspects of what both state and federal law requires.
So in your very diplomatic answer, what I'm hearing is that you don't think that the people that are supposed to enforce parity, the Department of Insurance, really know what to do about enforcing parity within the confines of their agency. Is that correct?
I think particularly with respect to these non-quantitative treatment limitations, there's a lack of understanding about how to implement the law in terms of what processes to go through, which is exactly what our compliance tool is designed to help them do. So we're very hopeful that they will take us up on our offer to help them use this compliance tool to take care of that very issue.
Mr. Clement, when did you offer them the compliance tool?
Well, we've been offering our training for quite some time, for over a year actually, and then we formally published our compliance tool in September, sent it along to them. We sent them the spreadsheet that they would need to use with it as well. So it's about 3 months now they've had that offer to use the specific tool that's been published and made available to all state regulatory agencies on our website. So, but it's been more than a year that we've been pledging that we would love to work with them and in a proactive way and help them come. I read the sentence. It's very complicated. It's no shame that it's no fault of theirs they don't understand it. It's a very complicated law, but that's why we want to help them understand the complexities of it.
But nevertheless, they have a responsibility to understand the sentence and to figure it out, do they not?
They certainly do, and they certainly do because of HB1 made it very clear that they have that responsibility.
And have they responded to your inquiries on this issue?
They have. I mean, I don't want to sound like we're blasting because we have had some conversations, ranging from good conversations to maybe not quite good conversations. But I do think there's some very smart people in there that would love to do the right thing. I hope that some of the problem isn't because instead of being, say, named the Thompson Forum or the Smith Forum or the Kennedy Forum, I know there's a gubernatorial election coming up fairly soon with maybe a certain Kennedy might be running for that. I would say that yes, they certainly, we've had some conversations, and they've been good, some of them. I'd like to stop having conversations, start sitting down and helping them understand this a little bit better.
So you've had conversations, but it would be fair to say there's been no movement forward on this issue?
Yes, that's correct.
One last question for now, and then I may have more. How do I ask this question? Have there been any complaints filed by this Department of Insurance since the passage of House Bill 1 against any insurance company for a parity violation?
David, correct me if I'm wrong, but I don't know.
There hasn't been that I'm aware of, and I think I would be aware of it.
And I just want to say this again. There have been no complaints filed by the Illinois Department of Insurance against any insurer since the passage of House Bill 1 over 2 years for a parity violation. Is that correct?
Yes.
That's all I need to hear. Thank you.
Okay, just briefly, 3 times you've told us that Illinois is doing it better than the 50. I'm going to tell you that scares the heck out of me. It seriously scares the heck out of me. Representative McDermott.
Thank you. We heard 2 specific instances of the negative results of lack of parity. I think we kind of skipped into this discussion by talking about parity. We're not talking about parity for parity's sake, are we? Would you like to enter into the record other than our 2 anecdotes? I'm not dismissing the anecdotes, but 2 people do not, a state make. Why is parity important? Let's go back to the very beginning and talk about why is parity important for us here today.
I mean, yeah, sure. Parity is important because it means access to mental health and addiction treatment. That if you have an insurance, if you're covered by an insurance plan and you're unable to access mental health and addiction coverage when you need it, then it's very hard to get that treatment without, 1, to get the treatment, or 2, doing so without financial ruin. So mental health parity is essential to making sure that people have access to treatment and to addressing our addiction crises in this state and across the country, and mental health crises, too.
Can I just quickly add that, I mean, we have a crisis in this country, and Illinois is certainly not spared from this crisis, of nearly 300 people dying each day of a drug overdose and suicide. Have you asked the average person or family, have you had a problem with the Mental Health Parity and Addiction Equity Activate? What's that? Have you had a problem in getting coverage for your mental health or addiction treatment from your insurance company? They say, oh, yeah, lots of problems with that. They just don't know there's a federal law and a very strong state law that's supposed to protect them. And it shouldn't be the burden for them to know that. It's the burden of state regulators to help them come into compliance with that. So I think if you ask people that have mental health issues and struggles with addiction who try to get treatment, they'll say that they've been having problems getting coverage, and that can directly lead to people dying. That's why it's important.
Okay, thank you for that. I think one thing I've learned here on the Mental Health Committee, and that we've all learned, is there isn't a family in Illinois or in the United States that's not affected by mental health issues, including my own family. Has there ever been a time where there was parity between what I would call regular health coverage and mental health coverage, either here in Illinois or anywhere in the U.S.?
No, I don't think there has been. The federal law is will be 10 years old next year, and we still have a long ways to go in realizing the promise of parity, which is at heart an anti-discrimination law, both federally and at the state level.
Yeah, and the reason that they needed to pass the federal law is because, no, we've never had parity. In fact, it used to be quite, and I know this from looking through every state's law, it was very common throughout history to have very restrictive laws requiring discrimination against people with mental illnesses and substance use disorders by their insurers. So we've certainly never had parity in this country or in Illinois.
Thank you. Talk to me a little bit more about this federal grant. I didn't really understand this. So under Affordable Care Act, states can apply for this grant and do their own enforcement, or this is what I'm understanding from what you've said so far, or states can rely on the feds to do it?
So the grant was the Centers for Medicare and Medicaid Services, CMS. They've been issuing a number of grants related to the implementation of the Affordable Care Act over the last several years, quite frankly, because they were unprepared for the fact that not every state would expand Medicaid, so they had a bunch of money left over. So last year, one of the grants that they issued that was not competitive, it was you're going to get the money if you apply for it. Illinois did thankfully apply for it. We actually did help them with their grant writing process, the Department of Insurance. And It's a grant specifically for several different parts of the Affordable Care Act, and that included implementing the Mental Health Parity and Addiction Equity Act in the individual and small group market, which is what the Affordable Care Act extended the parity law to the individual and small group market. So the Department of Insurance got that $1.4 million to do a number of things, but some of them very specific to parity enforcement implementation, including proactive enforcement of insurers and collecting information like what we would do in our tool for the insurers. So it's, I can show you, I can send you all the link on the Centers for Medicare and Medicaid Services where it lists what the state of Illinois Department of Insurance said it would do as part of this grant.
That might be really helpful for the committee, don't you think? So there are parity issues with large insurers, say, for example, my insurer, Aetna, and also the small group insurers, and they may be two separate challenges.
Right. So, and this is where health insurance, healthcare starts getting complicated. The state of Illinois is responsible for enforcing parity when it comes to individual health insurance coverage. So if I purchase a health insurance plan on the individual market, the Department of Insurance is responsible for implementing that. If, say, a small employer purchases a health insurance plan from an insurance company, Department of Insurance is responsible for enforcing that. If a larger employer purchases a health insurance plan from Aetna or Cigna or whoever, the Department of Insurance is responsible. Some of the super large companies that instead of purchasing health insurance, they pay for their health insurance benefits out of their own pocket,
right,
and then they hire Aetna to administer the benefits. That's not the state's jurisdiction. That's for the Federal Department of Labor. But that's the percentage of people who have an individual or a small group plan or a large group plan that was purchased and under regulation from the state, that's still a significant number, a pretty significant percentage of people. So, and the state of Illinois, the Department of Insurance is primarily responsible for that insurance, and that's what that grant is supposed to do, is to help them fulfill their obligations to enforce for that segment of the population.
Okay, thank you very much. I kind of, everybody lives in their own world of experience, which is, working for a large employer and, the mental health issues that affected my family. So, all right, now we're talking continuously about the Department of Insurance, and I noticed they're not here today. Is it the intention of the committee to hear from them at some point?
I don't understand why they wouldn't have thought they should be here today.
Were they invited?
It was a public hearing, and yes, they were invited. So, and we will be having a second hearing. I think it's very disappointing that they didn't feel it was important to be here. Representative Anderson.
Thank you, Madam Chair. First off, to the panel, thank you for being here. To the two advocates in particular, thank you for sharing your stories. I recognize that you, Mr. Timian, I think you had said that you were an unintended advocate, but here you are, so thank you for doing that. A few questions. First for Mr. Lloyd. Number one, thank you for preparing the survey that you did, that the Kennedy Forum did. There is an important, I think, notation in the survey, which is its limitations. You did it in a methodology that maybe isn't peer-reviewed exactly. I understand that because there is the inability to do it in a proper way. It appears from reading from the Heroin Crisis Act, though, that we have required this sort of a survey. Is that a fair statement?
Yes, to my knowledge, yes, that is a fair statement.
Okay, because it says that the DOI is supposed to proactively monitor discriminatory practices. Have they, I assume you've communicated with them, correct?
Yes.
Have they indicated a disagreement that a survey is the appropriate way to go?
Well, they have responsibilities under state law, and I mean, a survey like the survey we conducted would certainly not be exact, the exact methodology, but certainly they conduct form review before they certify plans, and that is one place where we encourage them to actually request the analyses, from directly from the insurers, so they can verify that plans are in compliance. They also have market conduct examinations that they should be doing on a regular basis.
Have they taken the position that they are complying with this requirement of proactive monitoring of discriminatory practices?
I think if you ask them, they would say yes. I would disagree with that.
Is there resistance to going forward with a more thorough study that you're advocating for here?
Yes, I think there is resistance, and the department will claim that it's resource allocation issues, but we think that at the very least they need to be requesting the analyses that plans are already required to do under federal law. That's a good first place to start, and then also working with us because we can help augment their resources in kind of how they target how they best target their resources in terms of looking at parity and making sure that plans are in compliance.
Do you think that the resource burden argument that they're making, is that one of obtaining the data or analyzing the data? How hard is it to ask, I guess, is my question.
I don't think it's difficult to ask. I think it's more, they would say more the latter. But we think that they have resources under this federal grant. We also think that they should be doing targeted reviews that will kind of help show them where potential problems are, and then they can do deep dives there.
Is the information that's being requested, is that in the nature of confidential where it would be difficult to analyze by a third party such as yourself? Or if you volunteered, would they be able to give you data that you could then examine on their behalf?
So we have asked 4 questions that they are requesting from insurers through the market conduct examination process. We have not yet been given that information. It's our belief that they're allowed to give that information.
They're not going to violate HIPAA or something?
I'm not an expert in HIPAA, but I do not believe that's the case.
Okay. And then since the agency apparently believes that they are complying with the law, and it sounds like there's a disagreement, is there more that we could do as a legislature? Should we amend the act yet again to be more specific about what, quite frankly, you're looking for? Would that be of benefit?
Certainly we think HB 68, Representative Lang's bill, would be an important step forward. And one thing that would do is, particularly with regard to these non-quantitative treatment limitations, is that it would actually make them submit the analyses that they are already required to be doing, to the state. So that would be a major step forward. The bill also has required information that would have to be provided on things like denial rates on the behavioral health side and on the medical side, and things that might actually indicate where red flags are, that then they could do the deeper dives to make sure the plans are in compliance.
Turning a little bit to the NQTLs, Mr. Timian gave a very good anecdotal example of his son getting better in the honeymoon, getting better with quotes around the word, getting better in the honeymoon period, and then suddenly the insurance company said, "Nope, he's good, out," right? It seems to me that I've heard that before, not in that context, but in different contexts. But I think it's also true in the more, I don't know what the correct term is, but let's say the physical aspect of medicine, that there are many disorders where you will apply a course of treatment that will have peaks and valleys as well. I don't think we have a problem anticipating those. It seems to me we're almost giving the insurance companies a bit of a pass by saying how hard it is to administer these NQTLs. I don't think what Mr. Timian described is all that unusual or hard to address. Can you speak to that?
Certainly, and I think it's helpful when thinking about these non-quantitative treatment limitations or the managed care practices that plans use, is to look at them one by one, because when it's a huge universe out there, it can be overwhelming. But if you look at each limitation kind of one by one and do the comparison and see how they developed it, you can see where problems might exist. So just a very simple example might be for hospital admission. If you had for the mental health and addiction side, if the standard, the medical necessity was that you have to be a threat to yourself or to others in order to be admitted, and if the standard on the medical side was that you need to be monitored continuously 24 hours, those are two very different standards, and the standards that we see are sometimes in place, one for the mental health and addiction side and one for the medical surgical side. And one is very clearly, you have to be essentially suicidal or potentially violent to someone else to be admitted. And the other is just you need 24, continuous, monitoring and care, which are two very different standards. And if an insurer or the Department of Insurance looked at those and saw those, they should be able to spot that fairly easily, that those are different.
And wouldn't it be fair to say that our medical professionals, particularly our psychologists, psychiatrists, our therapists, kind of understand this methodology and they know where those pitfalls are? I'm having trouble delegating this to the insurance companies when we have medical professionals who understand it, correct?
Well, yes, I agree with you, but I do think that these treatment limitations are an inherent part of any health plan, and so we just need to make sure that they're comparable and no more stringently applied on the medical side and the behavioral health side, and certainly medical professionals play a critical role in assessing when those standards have been met once plans are already in compliance with the Parity law.
Who's on the other side of the equation of making these determinations with the insurance companies? Are these trained medical professionals as well who are analyzing the coverage?
Yeah, so usually the way it works is they have, so when, like in Mr. Timian's case, when they did the review of his son's care, they would have a utilization reviewer, that's what they call them, and they say they have a manual, their utilization review manual, or their utilization management manual, they call it the UM manual. And usually the person initially doing that might not be a trained medical professional, but when they think it requires the expertise of a trained medical professional, they'll then refer it to a quote, clinical peer reviewer who is a peer of the attending professional with the same level of training, and that person will make a decision as to whether or not they think it's medically necessary. And oftentimes those trained medical professionals might not even be in the same discipline, however. So it might not be a child psychiatrist, it might be a gerontologist or something like that. That's some of the horror stories that we've seen. And that's something that where it falls into the comparable and no more stringently applied. Is that the same way they're doing it for medical care? I don't know. The answer is we need to see that examination, and it's impossible to know if they're complying with that part of the law unless they're doing an audit of their practices. How are we doing it for cases like Mr. Timian's, and how are we doing it for childhood leukemia or muscular dystrophy? And that's where we need to see the comparability in operation.
Sure. So you're telling me it's possible that in the peer review of Mr. Timian's son's case that a gastroenterologist could have been doing the elevated review? It's possible?
Certainly. I mean, there was a horrifying 60 Minutes story about 3 years ago where they had instances where there was people that didn't have any sort of formal training in psychiatry doing those kind of reviews for mental health care.
That's, to be quite honestly, absolutely ridiculous.
I'll mention that it was only in the appeal that it went to an external review. And so my feeling was that, of course, the internal reviewer has a bias in favor of the insurance company. And the external review and his report was very, I don't want to say defamatory, but he was very much saying this is obviously in need of this care because of XYZ factor. And he took the whole picture into account, whereas the initial rejection was just very much, it felt like it was, we're going to go down a bullet list, make checks. If we don't hit every check, it's going to be rejected.
Yeah, and I'm sorry that you experienced that. I don't think you're unique, unfortunately. Just a few more questions. One on this concept of the requirement to fail first. And I'm thinking of it oftentimes in terms of medication, but maybe there are other circumstances. I understand the need for that. That they want to try more cost-effective meds for the more expensive medications. But in this field, unlike a more physical disorder, fail first can often mean suicide, correct?
Yeah, so as you correctly identified, fail first by itself, that's nothing illegal about that, and they use that for medical care. It's routine, fail first or step therapy, as they sometimes call it. But, a lot of insurers, I don't know if this is still common practice, but certainly used to have the practice that you would not be given Suboxone or methadone coverage until you'd failed twice or 3 times at outpatient treatment. Was that an overdose? I mean, how do you, is it a note from the coroner? Is that how you know that they failed? And I think that while I would certainly not call for just eliminating fail first, again, you have to look at what are the requirements for fail first for mental health and substance use disorder treatment, and are they comparable to and applied no more stringently, both as those written protocols are, but then also when you do the review, for like when they apply that, how are they determining whether or not the failure has occurred? How is that discretion being applied? And that's comparability and stringency in operation. So I think that fail first, it's a dangerous situation, like you said, with people with mental illness and substance use disorders, because it could be death, could be failure. But again, it's comparability. We need to see that, and that's the main issue here.
So a lot of it is you simply don't know at this point. We're speculating a little bit, but you don't know, and without the data, we can't really make an evidence-based decision, correct?
Yeah, you can't know for sure. When an insurer says, oh, we're complying with the laws, well, how do you know? Have you done the analysis? And if you haven't done the analysis as an insurer, you can't sit here. If you had them here testifying, they couldn't look you in the eye and be truthful and saying, we know we're in compliance, unless they've done an analysis, both in terms of what their written protocols say, but then how are your utilization reviewers operationalizing those fail first protocols? So that's impossible to know without that analysis.
Sure. And I would ask one thing, just throwing it out there. I bet that we could change this protocol if we required a burden shift on the fail first side of things. And what I mean by that is, let's say that an insurance company denies a particular medication, right? And the doctor maintains that this is medically necessary and the step protocol isn't required. Well, what about we change the law such that at that point, the medication is required and the burden is now shifted to the insurance company to prove that it can't be?
Yeah, I think you could. You certainly could. I think New Jersey may have done that, and I think New York may have done that too. So I think that would absolutely be something you could look into doing.
So you'd shift it away from the consumer, who has no idea about the law and usually has no access to justice in that sense, without being very fortunate.
Yes.
My last question for Mr. Timian, but also maybe for the two two professional, I don't mean any of you aren't professionals. You would describe the circumstance where you ran out of coverage. You left your son in residential or a crisis stabilization unit, or whatever it was, and Medicaid picked up the bill.
Right.
So we shifted from your private insurance, which denied coverage, to a state-funded system, correct?
So this is actually a bigger issue, and one that I've been more involved with, and the repercussions of this are a lot worse than you think. There are families that give up parental rights for their children, and I know there was a House bill passed on this 2 years ago that just started being enforced about a year ago, but they relinquish parental rights because it's the only way that they can get adequate mental health assistance for their children. And this is very specific to children and children that need residential, but we're talking about violent offenders or highly, with very dysfunctional psychoses that parents cannot manage on their own. But this is frequent enough that one article I read that was saying there was 1 child a day in Illinois that this was happening to. But the only way that a lot of these parents have to fund the treatment is by putting the burden completely on the state and creating, for lack of a better terms, a welfare state, when a lot of these families had the medical coverage to begin with. They were just denied it. And whether that was Medicaid or whether it was private insurance, they were denied the necessary coverage. And this is institutional in that there are not openings for these children because insurance doesn't pay for it. Therefore, there are not enough providers that will open up their doors. So it's a very circular problem.
Yeah, and it sounds like it's more draconian than I even imagined with this idea of giving up parental rights. But what it sounds like from a monetary math standpoint is, it seems to me that if we require the surveys that will tell us whether our insurers are complying with this law, that perhaps you wouldn't have had to do what you did, which would have meant that the state wouldn't have had to pick up the bill, which means all we do is ask people to follow the law and we save money. Would that be an outrageous statement?
It would be outrageous. I think compliance is
It would be outrageous?
It would not be
It would
outrageous.
not be.
Right, I'm
Thank
sorry. I'm told I mumble sometimes. So compliance is hard, especially with mental health and the burden of who is allowed to make these recommendations. And again, my only experience is in the residential and child psychiatry, so it's kind of isolated. But you mentioned the rubber stamp. The doctor says approved. Who's going to approve these higher levels of care? Right. And I think that those questions need to be answered, because right now it's kind of a free-for-all.
Sure.
And it's gotten to the point where the hospitals are playing by insurance's rules. Therapists or interventionists are saying you can't go to an inpatient hospital until they've tried to hurt someone else. So it's already too late at that point.
Yeah.
And so we've become a very reactionary situation instead of trying to be proactively fixing the problem, which, I guess we're supposed to be doing.
Well, thank you. Thank you very much for that. Thank you, all of you, for testifying. It's clear that while we might have parity in law, parity in action doesn't exist. So I hope that we as a panel or we as a committee can move forward on your recommendations. Thank you for bringing them. Thank you, Madam Chair.
Representative Wallace.
Thank you, Madam Chair, and thank you to the panel for being here. This is something that is very close to home for me, especially hearing Matthew and William's testimony this morning. I have a foster child that was born exposed to opioids. I've worked in the mental health care settings across our state, and I've seen a lot of this firsthand. We've talked a lot about the legality, federal and state regulations, and I know that there are some things that you alluded to, Matthew and William, in your testimony, which is basically just provide us the coverage necessary, right? Just allow access. But I'd like to ask you to take a moment and describe to this panel or this committee what you would like to see in a behavioral health care model that works for your care needs, William, and for the needs of your son, Matthew.
Thank you for your question. I think for me, it's just essential to feel like there is ample opportunity or ample option to where, especially like in a case as Mr. Timian alluded to, it's like, a place like Rush or a place like Northwestern Hospital, or even where I was at Swedish Covenant Hospital when I was essentially booted from there to go to the state hospital, Reed. It was as if for me to be admitted to one of those other, what I would call like the upper tier inpatient or outpatient programs. It was almost like I would have had to like gone out and hurt somebody. Just the fact that I was experiencing psychosis and suicidal ideation wasn't enough for me to remain in Swedish Covenant. But instead, because I had Medicaid, I was deemed not worthy, or I wasn't cleared, and that's when I was it was like compulsory that I was to have an ambulance come, put me in a gurney, and then reroute me to Reed Hospital. And that was like the most humiliating experience I think I've ever had in my life. And even up and down between then and now, where I have a private insurance, it's as if I think about the people that I see in the mental health community, and they don't have, it's like they're being segregated targeted, they're being ostracized, they're being kind of put in this one track where it's either, you have this option or you're going to live on the street, or you have this option or you're going to go to Cook County Jail. And I just don't feel like that's fair. And I would just like to see, I don't know if there's like this parity, I'm not very informed on the parity laws and things of that nature, but I would really like to see it where if I'm a private physician, if I have a private practice, or if I'm, Rush Hospital or Northwestern Hospital, that I have a moral obligation to be able to operate in Cook County or in the state of Illinois, that the programming that I offer for psychiatric care, I have to not only take people with Blue Cross and Blue Shield, but I also have to take a certain amount of patients who either have no income, no insurance, or who are on Medicaid, because that to me is like, that's egalitarian society. That's like fair. That's equality. And what I've seen, it's not fair. Where, like I said, just to get a hold of my psychiatrist, I wasn't allowed to, because it was like a clinic, a public clinic, where people were on Medicaid or didn't have any income, but you could not have direct contact with the psychiatrist. Whereas when I've had a psychiatrist in private practice, you can page them, you can call them, you can email them. That to me is like that's humane. Like, it's inhumane when you are someone suffering from psychosis and from suicidal ideation, and you can't even communicate with your psychiatrist just because of bureaucratic policy. That to me is like the most inhumane thing I've ever seen. And to end my kind of anecdote here, I just think that it needs to be more, there needs to be equity, there needs to be equality, and like access for all, not just the few who have really good jobs and really good HMOs. I just think that's a travesty.
Can I ask you, are you in an MCO or a fee-for-service type of program?
Currently?
Yes.
I pay it through my employer, so like I'm in a HMO, yeah, through my employer currently. But my anecdote was during my time when I had, I was actually working overseas for an NGO. I moved back to the United States, and I didn't have a job for about 6 months, and that's when I was on Medicaid, and that's when these things happened to me.
Okay. And I think the piece, too, that the committee needs to realize here is that if our private insurance companies are covering what they should cover, we would save taxpayer dollars, because a lot of this wouldn't be shifted to Medicaid. So that's one of the issues that we need to get people to understand. So when we talk about parity, people don't understand the practicality of what that actually means to taxpayer dollars. Representative Wallace, do you have another question?
Yes. Well, I would love for the other advocate to explain a little bit more about what he'd like to see for his son, and then I might have a follow-up.
Yeah, I appreciate the question, and I alluded to this earlier, and I feel that, and I don't know the answer to this, but I feel that the entire situation needs to be taken into account. My son, for example, having been in inpatient hospitalization, I mentioned 6 times, I think it's been over 8. Within a 3 to 4 year period. The hospital, every time, first of all, we only go to the hospital that has an open bed. And if we go to that hospital, depends on if we meet their criteria that night. So it's very much, it's a waiting game. I've spent 20 plus hours in an emergency room waiting for a hospital to open that we can go to. I understand that, but when I then give them a stack of papers every time saying, here is every intake and discharge form that we've had from all of our previous hospitalizations, I would like it if they would take those things into account, if they would read them. If they would, it's obvious that they don't. Because they're overworked. They're doing things very quickly. But they're treating the moment. They're not treating the condition. And they're trying to stabilize this child to prevent them from being suicidal or homicidal, and then they're pushing them out the door. There is zero regard for the fact that this has been going on for the last 3 years and on a regular basis. Or in one case, this is the 3rd hospitalization in 2 months. that have all been violent. So obviously, a revolving door in the hospital is not going to fix this. It's going to treat it for a night. And, I've been in a situation where he has legitimately attacked another resident in the hospital, punched a hole in the wall, pulled a pipe out of the wall, started wielding it, and then was discharged the next morning because insurance said that he was no longer symptomatic. And the hospital, obviously, they're not running a charity, so they don't, their hands are, I understand where they're coming, I understand where everyone's coming from, but it's not fixing the problem. And then he was discharged and put right back in the same hospital the same night because he was still homicidal, irrational. So no one is taking the whole picture into account, and I think that we've turned this into a drive-through service. And oftentimes these mental illnesses require long-term treatment. And when we talk about children, we're talking about avoiding putting the burden on the state in the prison system, or because these kids that have these problems, they turn to, and we're criminalizing mental illness in a lot of ways, and then we have the jails which are overrun, and we have shootings which shouldn't happen because they could have been avoided. And this is a problem that has a solution, but it's a very humanitarian one, and it seems costly up front. But I think the long-term gains are much better for society. So, I mean, that's all I have, is that we're not taking the whole picture into account. We're putting a Band-Aid on there, giving him some new pills maybe, or the same pills. We're just changing the dosage. And there's no follow-up. There's no long-term care. It's all just very much, we're pushed out the door, given a pamphlet with resources, which is too much to bear when you're dealing with a violent child, or if you yourself are having these problems, you don't have the resources to take care of this stuff. So there is no real long-term care for these situations.
I want to say thank you for sharing even more about what you would like to see and how we can do things better in terms of the application of all that we talked about that's already on the record, everything that's already law. I do find it quite astounding that as we standardize almost everything, right? We expect our children to go and have these standardized tests and meet these benchmarks and measures, yet we don't have a standardized way to assess what's happening with the implementation of this law. And I think, obviously, as we move closer to session, these are probably some really great things that we'll be able to take on. And so I appreciate every single person, but particularly those personally dealing with the issue.
Okay, thank you very much. A lot of really important information. I think committee members may continue to have more questions, so we'll be reaching out to you. And I'm going to call the second panel then. Second panel is Irvin Sam Majensky, Director, Office of Healthcare Systems and Financing, American Psychiatric Association. Merrill Kamen Sosa, Executive Director, Illinois Psychiatric Society. Joshua Nathan, President-elect, Illinois Psychiatric Society. Please state your name before you speak.
All right. My name is Sam Muszynski. Actually, my title is I'm Senior Policy Advisor and Director of Parity, Implementation and Enforcement at the American Psychiatric Association. And thank you for the opportunity to be here today. I've enjoyed the dialogue before this, and I wanted permission to ad-lib a few observations. The opening one would be, I would love the opportunity to supplement the written comments I made that would guide.
Can you check to see if your mic's on? No.
Is it on now?
Maybe fix the mic a little bit. There you go.
Supplement the written comments I already made based on some of the questions that were given here today, because I think it would be informative to this committee to know the progress that's been made in other states. I personally have interacted with 19 different states, whether at the insurance commissioner level or at the attorney general level, and I can tell you there's a lot of good things going on out there that, and most of those states realize that there is not a fiction section in a law library. okay? That the parity is law, and it needs to be enforced, and while it is detailed and complex, it mostly involves work. It's not, every problem has a solution, and this puzzle definitely has a solution as well. So it is what it is. So I will just extract briefly from my written comments, which I submitted to you, and what I really want to do is, in the context of barriers, I have been an attorney and a policy analyst in the behavioral field for over 40 years, and my primary duties over those 40 years have been to work with both public and private insurance programs. So I've seen a lot over that time, and I'm guided by a lot of different principles. One is that insurance companies, like water, will find their own level. And in this case, in the parity law, the obfuscation and the avoidance of the burden of compliance is one that has become a problem. And I know I've been in health plans under non-disclosure agreements to consult with them about what they do, and I can tell you on balance, they really haven't tackled the issue of how to comply with this law. And that's not really intended to be an indictment, but we need to move the ball down the field a little bit further than where we've been. And you've heard a lot about different barriers to coverage and access over the course of the morning, and I don't want to repeat them. The focus that I really wanted to bring to your attention are two issues that are non-quantitative treatment limitations. The first is the issue of network adequacy, or the availability of in-network providers, and closely related to that is the issue of what insurance companies pay behavioral health providers, whether at a facility, an outpatient clinic level, or an individual level as a psychiatrist or as a psychologist. And suffice it to say that the lack of in-network access to behavioral health benefits is a parity problem. And I would also parenthetically note that in several states, attorney generals have begun to realize this is also a consumer protection problem. If you were offering a product and you can't deliver the product, we got a problem. If Amazon couldn't deliver 40% of the time, what would happen? They'd be in big trouble. So network adequacy, I'm going to try to explain how it is a non-quantitative treatment limitation. And as you heard the definition of what it is. It's something numerical, or not numerical by nature, but it otherwise limits the scope or duration of the benefit. When a person buys a health insurance policy, they have a sense of expectation that they are able to access a provider on an in-network basis under the most favorable financial conditions on a timely basis and so on. When that doesn't happen, it limits the scope of the benefit under the contract, and therefore subject to non-quantitative treatment analysis under the parity law. I would note for you that this is not just an opinion. The study that was referenced earlier by Mr. Lloyd that was done by Milliman has documented on a 50-state basis with a gazillion claims in the study over a 3-year period that out-of-network utilization for behavioral health benefits in Illinois, I forget what the exact number was, but across the country is sometimes 4 to 8 times greater utilization on basis. And what was correlated with that study was how low reimbursement rates were to behavioral health care providers in addition to that. We believe that poor reimbursement rates are one of the key factors that influence providers to not participate in health plan policies. But the gravamen of the parity law is that access on a timely geographic or other basis to the behavioral benefit has to be comparable to what happens on the medical side. And the out-of-network utilization data kind of shows that it's really not comparable at all. So we have an issue. Now, plans must comply with a variety of standards. They have to comply if they're health plan accredited by NCQA or URAC. They have to comply with those standards. Or in the case, Illinois now has a new network adequacy law, whether I forget the provider to population ratios or, within 30 miles and so much time. But that's only one side of the coin. Because on paper, while these health plan networks can look adequate and can pass muster under a cursory review, the real question, especially under the parity law, is how do they actually perform? And even by their own accreditation standards, independent of the parity law, health plans are required to monitor their performance. So high out-of-network utilization and emergency room utilization to access your mental health benefit ought to be more than a red flag. It should be setting up flares that we need to look at this issue. The disparity in utilization is not per se dispositive of a parity law violation, but it's certainly something that warrants closer attention. So there's separate inquiries. Often state insurance commissioners will say, well, look, they meet the standard. That is only half the question. Meeting the standard on paper is not dispositive of whether you're compliant with the parity law. And we believe that the lack of access to in-network providers across the spectrum of care is one of the key access issues that we're confronted with, and one of the key things we need to bring into compliance with per the parity law. So why is it a parity violation if someone can't access in-network? One easy way to look at it is the financial terms for out-of-network access are quite less favorable than they are on an in-network basis. And out-of-network utilization only works, in fact, if your plan has an out-of-network benefit. A lot of plans don't. So if you can't access in-network and you have no out-of-network benefit and you don't have the cash to do out-of-network, the benefit that you were offered is illusory at best. And I could go on with other kinds of implications. My point is that when you really pick it apart, and I offered this in my written comments, there are ways to categorize exactly what the parity disparities are when you can't access an in-network benefit. Now, how do you look at this? And there was a lot of discussion about what Illinois DOI is doing or not doing, but I can also offer from other perspectives from other state insurance commissioners. This problem is solvable. There are ways to look at the law and how compliance can be measured by a health plan. And an important point that Tim made that really shouldn't be lost here is it doesn't matter how many resources or lack thereof a Department of Insurance has. The burden for compliance with the law is on a health plan. It's not on the Department of Insurance. It's the Department of Insurance's job to enforce the law. So the Department of Insurance job needs to be to communicate and detail what the expectations are of the health plan as to how we want you to justify what you do. I mean, it was also mentioned earlier that, de facto, the parity law is an anti-discrimination law, and it's not easy it actually is easy to overlook that fact. I really feel strongly that a lot of plans just really haven't done the job because it's hard work. And so what's the problem with transparency, by the way? Why can't we have more transparency? This is one of the biggest issues we're dealing with at the federal level. If a health plan says they're in compliance, that should require more than a unilateral attestation that we're in compliance with federal law. I mean, who gets to count the centrifuges? Them? We should be the ones counting, or we should be having them evidence the fact that there is some level of accountability to the law. So why no transparency? If these questions, I don't care how hard they are, there should be some more disclosure and forthright revealing by the insurance companies as to what it is. The second issue that's closely tied to the issue of network adequacy, obviously if an individual or a hospital chooses not to participate, there can be a lot of reasons why. They can feel that the medical necessity criteria and clinical guidelines used by that company are really not a community standard that they want to live with. They can look at undue utilization management protocols. It was referenced earlier, weekly phone calls to decide how you're going to justify continued stay. They don't do that on the medical side. I've been involved with overturning a number of procedures by different health plans where we call them the star chamber interviews. The physician wanted to see the patient beyond 12 visits, and they had 5 reviewers from the health plan company on the phone with my physician for an hour-and-a-half interview trying to justify what this is. Whoa. Have you ever had your PCP have to be on the phone for an hour-and-a-half justifying why you needed this procedure, whatever it was? So there are a lot of reasons that providers don't, but the key one is reimbursement rates, and I really have to drive that home. I don't want to sound like I'm pleading for more money, but the fact is you can't operate at a loss. And so it's just something that needs to be reconciled with. So I included a couple of recommendations in my written comments, and I really want to emphasize that it's feasible to do what's required to do to kind of evidence compliance with the law. And we'd be happy to provide additional written material and experience and so on, and help you frame questions that you may want to ask the Illinois Department of Insurance here about how to move forward. Thank you.
Before we go on, when you talk about reimbursement rates, are they the same in all 50 states, or do you see a difference?
Oh, there's a wild variation in the 50 states.
So where would you rank Illinois?
Probably in the middle of being bad.
Thank you.
Bad enough.
Thank you.
First, my name's Merle Sosa. I'd first like to thank the House Mental Health Committee.
Check your mic.
Can you hear me now? Okay. So I'd first like to thank the House Mental Health Committee for taking the time to have this hearing and hear information regarding mental health issues. My name is Merle Sosa, and I'm the Executive Director of the Illinois Psychiatric Society, but today I am not testifying on behalf of the Illinois Psychiatric Society. Today, I am testifying as the parent of a daughter with serious mental illness, including ADHD, depression, and anxiety. Also, today I'm going to give an example of the most recent parity violation that I've gone through. I had another parity violation in early 2016 with my daughter also. So if later you'd like to hear that, I can explain that too. I wanted to share with you an experience I have just gone through with my daughter Bella, who goes to college at Lease McRae College in Banner Elk, North Carolina, and she's on my Blue Cross Blue Shield of Illinois PPO policy. Unfortunately, my daughter has been dealing with serious depression during her first semester at college. This is not a new thing. She has been in the inpatient units 13 times and was in residential care for 2 years. Initially, she wanted to go to an inpatient unit in the hospital in the area where her school is, but the school said that if she went inpatient, she would lose her semester credits. So instead, we have been trying to get her in to see a psychiatrist in the area. She lives in a small town in the Blue Ridge Mountains. There is no public transportation. There is no Uber or Lyft. So any place she has to go, she has to get a friend to drive her. So we were looking for a psychiatrist within a 17-mile range from her school, because 17 miles away is a town that's the biggest town in the area. So we both my daughter and I called each of the psychiatrists that were listed in the provider directory in that area. The psychiatrist in the town where my daughter is located did not respond to either my daughter or my phone calls. 3 other psychiatrists in the network had the same phone number. When each of us called the number, it just kept ringing and ringing. I have no idea whether it was an actual number or not. Another psychiatrist's phone number was for a clinic, and on the voicemail it said, there is no psychiatrist in this clinic. There were 2 psychiatrists in the provider directory who were members of the American Psychiatric Association, so I emailed both of them. Only one responded. She said she would have been happy to see my daughter, but she has lived in Indiana for 2 years. So out of all of the psychiatrists on the list, only one responded to me, and she was not able to see my daughter. Finally, I received a call from the administrative person at one of the psychiatrists in North Carolina, and they said that the psychiatrist in the provider directory only works in patients. He doesn't accept new patients. But they did have another psychiatrist who is accepting new patients and would accept Blue Cross Blue Shield PPO, except that she's not in the provider directory, and from either a physician or a psychiatrist, which is not required by my policy, but they required that. So my daughter had to go ahead and go to another doctor, get the referral, and then provide that to them. But that particular psychiatrist was going to be out of the office till December 18th. My daughter is coming back here December 8th. So her first appointment she can go to is January 16th. I called customer service at Blue Shield to try and see if they could help. So they called all the psychiatrists in the network, and they got exactly the same responses that I did. While I was on hold with Blue Cross Blue Shield, I noticed that they had www.ndlive.com on the insurance card, which is a telehealth company. So I checked on that, and they did have telepsychiatrists. And so my daughter contacted a psychiatrist on the policy, and she found out that the telepsychiatrist would not be able to prescribe stimulants because of the requirement that stimulants had to be prescribed on a paper script, and so therefore she couldn't use a telepsychiatrist. So finally, that's basically, she is going to see the psychiatrist in January, but in my view, the Blue Cross Blue Shield provider directory is completely inadequate and violates the rules regarding network adequacy. It is clear that the provider directory has not been updated in at least 2 years. Also, I have been informed that it is the position of Blue Cross Blue Shield of Illinois that it is the provider's responsibility to let Blue Cross Blue Shield of Illinois know if they are moving or if they no longer are going to be in the network. Based on the Parity law, I believe that it is the insurance company's responsibility to regularly update their provider directory to make sure that the provider phone numbers are accurate and the providers are still in network. Also, I contacted IDOI to see if they could help me with this. The chief of staff felt bad about the situation, but he didn't recommend that I file a complaint, nor did he offer to help me get care for my daughter. I was recommended the Kennedy Forum to file a complaint with the Attorney General, and the Attorney General has been very helpful. They contacted Blue Cross Blue Shield. They are going to work on the issue with the network adequacy. So the Attorney General's office has been more helpful. So I am just providing this information to you because I think I have just gone through a parity issue involving network adequacy, and I wanted to give that example of what patients have to go through with regard to these directories. And so I hope that's helpful to everyone. And as I said, I had another parity violation last year, and I can share that as well.
Right. So no questions? Okay.
Not yet.
Hi, everybody. My name is Joshua Nathan. I am a psychiatrist practicing in Illinois, and I'm the president-elect of the Illinois Psychiatric Society, which is a district branch of the American Psychiatric Society. I am really honored to be here representing Illinois psychiatrists, Illinois physicians who specialize in diagnosing and treating mental illness. On behalf of the 1,000-member strong Illinois Psychiatric Society, I want to thank Representative Conroy and really the rest of the committee for convening this public hearing and beginning the important public discourse on bringing mental health beyond whispers and out of the shadows. I really, there's a lot of things certainly we can talk about when it comes to barriers to mental health. I expand on a few things in my written testimony that I'd like to highlight here today. 3 basically areas of stigma that can really be addressed, I think, by this committee to improve access to mental health. One thing I was going to highlight is something that's been really talked about quite a bit already, of course, which is the general concept of parity as a way to reduce mental health stigma. The idea really of mental health and mental illness being exactly equal to, having the same weight and bearing, and really being no different than other medical illnesses. In my view, conceptually, it's really simple. Mental illness is medical illness. A line between the two is kind of really just arbitrary. Fortunately, there are currently some laws nationally and in Illinois, as we've heard about, that make mental health parity the law, and they require insurers to honor this concept to some degree. Unfortunately, as we've heard, there's a lot of work to be done. We have partial parity at this point, and so it's only partially helpful. We would really like to see that insurers and healthcare coverage entities cover all illnesses that are listed in the Diagnostic and Statistical Manual, or DSM, or in the International Classification of Diseases, ICD. It's really that simple. If it's an illness, it should be covered. And unfortunately, we also have some problems with enforcement, as we've heard about. I think the laws are pretty robust already. It's unfortunate that the Illinois Department of Insurance really waits for consumer complaints before it investigates a problematic coverage situation. And it's really disheartening to hear some of the stories that we've already heard. Not everybody is as capable as Merrill is, but for most patients, the IDOI is waiting for a patient in the middle of a mental health crisis to proactively learn about the law, understand how they're being treated differently, and then to find and access the appropriate complaint mechanism, and then disclose their personal health information to a state agency. It should be as simple as, just like if you have a heart attack and you go to an emergency room, they might admit you. If you have suicidal ideation and you go to an emergency room, first they're going to check your insurance network. If you think you need to be admitted, and decide if you can stay at that hospital or need to go to a different hospital. It makes no sense. And as we've heard, failure to improve the parity laws to be as thorough as we need them to be is going to allow millions of people to suffer and maybe even die from these horrible illnesses, medical illnesses of the brain that we know how to treat. Failure to adequately enforce these laws is going to allow those millions of people to suffer and possibly even die because their insurer is not obeying the law. We would urge and recommend that the committee review in detail IDOI's current protocols for non-consumer complaint pre- and post-market parity compliance, and we would be happy to provide the committee, as we've already done, with additional information about what IDOI's peers are doing elsewhere. It's a team effort in terms of establishing and securing true parity. On a second topic related to parity, as we've already started to talk about, is the idea of reimbursement and payment for psychiatric services. So to achieve true mental health parity, we have to pay psychiatrists at the same rate we pay other physicians. It's unfortunate that not everybody is aware of this, but psychiatrists are physicians. I've completed medical school, I trained in residency, so why am I not paid the same as other physicians? The Center for Medicare and Medicaid Services already said that lower reimbursement rates can impede access to care, and the Illinois reimbursement rate is particularly problematic. The rate for psychiatrists was last set in 1996. It has not, I'm sorry, what? For Medicaid, I'm sorry. The rate for psychiatrists by Medicaid was last set in 1996 and has not changed since. So naturally, it's among the lowest rates in the country. I think about 30% of what Medicare pays. This means that psychiatrists really just cannot afford, they simply can't afford to provide services to Medicaid patients. And highlighting the problem, since the Affordable Care Act was passed, Medicaid enrollment in Illinois has increased, but overall spending on psychiatric care has gone down by half, about 50% in the past 3 years. So we intend to introduce legislation to increase the Medicaid reimbursement rates to the level of Medicare rates. And with parity, with true parity, medical reimbursement will increase access to psychiatric care for millions of Illinois citizens. And then the third thing I'd like to highlight is a slightly different form of stigma and disparity. Physicians do not do such a great job of taking care of themselves, and there's a really institutionalized form of stigma and mental disparity that's preventing just untold numbers of physicians from getting the psychiatric and mental health care for themselves. According to the American Foundation for the Prevention of Suicide, the physician suicide rate is about double that of non-physicians, and it's among one of the highest of any profession. And by some estimates, 15% of physicians consider suicide, 30% are suffering from depression, which is about 3 times the national average. And the primary reason, through several surveys and research studies, that physicians suffer so greatly is that many state licensing boards that determine whether somebody can work in that state, including Illinois, ask physicians during the initial and renewal licensure application process to make a statement about their current or past mental illness without asking about other medical illnesses. And in Illinois, answering yes leads the Illinois Department of Financial and Professional Regulation to require an immediate mental health evaluation and repeat evaluations every 3 months just to prove that you are not too impaired to practice. So many physicians are afraid to seek care for fear of jeopardizing their careers. We recognize that protecting the public by making sure we have capable physician workforce is one of our regulatory agency's vital functions, but collecting physicians' medical histories of any sort is really just irrelevant and actually dangerous. I think that, in fact, by asking about mental illness and thereby scaring physicians away from treatment, the IDFPR is actually failing in its duty and is actually endangering the public. Even the Federation of State Medical Boards has declared that such questions should not be part of the physician licensure process. It's a really simple change, but it can make a profound difference for the public good and will harm no one. So I look forward to the future actions of this committee, and I want to thank all of the members of this committee for listening and for your questions coming up. And thank you to David Lloyd and Tom Bunting for organizing this public hearing.
Thank you. Representative Lang for a question.
Thank you very much. To Mr. Muzinski, did I pronounce that correctly? Perfect?
Perfect, yeah.
First time anyone's ever said that to me. Thank you, sir. So you said you could provide to DOI a series of questions that would lead them down the road of fixing some of these problems. Could you provide us with those questions so we can take a look at them?
Yeah, I intended to say that I could provide them with you. You can do more with them. I've spoken with DOI. Tim and I have kind of worked in tandem many times, and I think it might help the committee more to understand what the questions are than DOI.
So you say you've met with them many times. Tell us about your experiences with them.
It was very cordial.
That's not really what I meant.
We last met in August, the end of August in Springfield. Yeah. We met with the commissioner, the chief of staff, and general counsel, and we had a very good discussion. We made the training offer at that time and suggested that, based on our work with other states, that we had kind of developed a regression line, how to make this more efficient and feasible for state regulators to look at health plan compliance. But there's really been no follow-through or follow-up with that.
So it was testified previously by, I think, Mr. Lloyd, that he's made several inquiries at DOI to try to get some response to your offer. You haven't received any information back from them either, right?
Yeah, no, and you know, they're not obligated to be trained by us.
Of course not.
But I think what they are obligated to do is to be transparent in the details to what they have done to ensure that health plans are complying with the law, and if there's never been an advisory bulletin to the plans suggesting what the expectations are if the state were to ask for documentation about compliance, it just kind of suggests that it's lying fallow at the moment. And the consumer complaint tactic, for all the reasons you heard, is just not the right way to go. The compliance with any law, federal or state, is not dependent on somebody complaining that somebody's not compliant. I mean, that's a logic algorithm I haven't quite figured out yet.
So what you're saying then is the law, and it shouldn't be up to a victim or a consumer to trigger a department review of whether the law is being complied with or not.
Yeah, I think that it's similar to other laws. There's proactive diligence and oversight by state regulators, and it's not just in the insurance realm. It's whether it's in consumer product safety or welfare or whatever it is.
Are we getting proactive action by the department?
It does not appear at the moment that you are, no.
Too diplomatic, sir. Are we getting proactive action by the department?
So I can take off my Henry Kissinger hat?
Yes.
Okay, yeah. No, you're not.
So that's the honest answer,
you're not.
Correct?
Yeah, and the troubling part, is that I've been inside enough health plans to know that they've just kind of made stuff up, and they really haven't done the requisite analysis to justify how they're in compliance with the law.
And so we have this anomaly, would you agree, that we have the strongest mental health parity law in the country, but other states are doing better at enforcing their weaker laws than we are?
Yeah.
And do you
That's
have
unequivocal, yes.
Do you have a list of best practices you'd like to share with this committee at some
I'd be happy
point?
to share them with the committee, what best practices would be.
And are these best practices that would be suitable for legislation?
Yeah, actually, a version of what we did with our compliance tool was codified into Tennessee law for the Medicaid parity enforcement in Tennessee, and we think we've got a shot at a few other states. Just parenthetically, I would note that this is just not something we dreamed up and did something with. We interact regularly with the key federal regulators, and when we developed this, we went to a half a dozen states who have been kind of in the vanguard of compliance enforcement. We beta tested what we came up with. We got the blessing, both formal and informal, of a number of the active states that said, yeah, this really makes sense, and this is the way to approach the issue. So it's not me selling some brand of whatever that was just made up out of thin air. It took us 18 months to get to this point, and like I said, a lot of beta testing with regulators.
So just as you have interacted with DOI, I assume we've interacted with certain insurance companies along the way, correct? What has their reaction been to your comments that parity laws in Illinois are not being complied with by the insurance companies?
I haven't had a direct conversation about Illinois with an insurance company. They've been more generalized discussions about the compliance issues that the insurance companies face.
And what have those discussions centered around?
That they're asked to justify their compliance in different ways, and they get different questions. And it's true that some of the insurance commission staff around the country are asking some of the wrong questions, which is why we started undertaking actually training insurance department staff where they were willing to have this training. You know, probably because I live and breathe it, at some level, the law is complex and complicated, but it's quite possible to simplify the law. It's really not that hard. I mean, the sentence Tim read, it's true, it's kind of confusing, but when you dissect it and you make it into a logical order that's actually been blessed by the people who wrote the rule, it's pretty straightforward. It's logical.
Is it your position, let me not say it that way, I don't want to put words in your mouth. What would your position be if somebody made the statement that insurance companies are purposely putting barriers in front of insureds relative to their mental health parity or responsibilities?
Well, you know, there's malicious intent, and then there's what I call ignorant intent, or just not paying attention to what they're doing.
You think insurance companies are ignorant of their responsibilities under the law?
I'd say they're less than aggressive sometimes in fulfilling them.
So that goes back to my question. Do you think insurance companies are purposely putting barriers between insured parties and their treatment?
Yeah, I do, and I'll use the network adequacy as a good example. That when you can't access a benefit in network, and let's not fool ourselves, plans know their directories are kind of bad, all right? So if you know that, it's kind of an indirect utilization control mechanism because people can't get what they're promised under the contract. So,
as Dr. Sosa described to us.
Exactly. So is that intentional? It would be absurd to suggest they don't have knowledge as to how poor their directories are. And it's kind of a lame excuse to say, well, it's the provider's responsibility to make sure that we're informed. The providers aren't selling their product. The plans are.
And when you provide to us best practices, will comments on this issue be part of that?
Yes.
All right. Just one or two, thank you, by the way. Just one or two questions for Dr. Sosa. First of all, your story is appalling. And I don't think there's anyone on this committee that doesn't share your concern about what your family's going through. Have you brought this issue, it may not be directly a parity issue, but it certainly is an access issue. Have you brought this to the attention of DOI?
Yes, I contacted the chief of staff, who I had met at the meeting with Sam, and he was very nice and listened to my problem, but didn't say, well, you should file a complaint, or let me help you, I'll contact Blue Cross Blue Shield. He didn't do any of that, and he didn't contact me back or anything. So I talked to David Lloyd at Kennedy Forum, and he suggested I contact the Attorney General's office, and so that's what I did. I contacted the Attorney General's office, and they asked me to file a complaint, which I did, and then they also contacted Blue Cross Blue Shield, and we're working, but he found out that I had found a psychiatrist filing, and so now he's going to be working on the aspect of the network, of the provider directory network adequacy issue.
Relative to you, or relative to the thousands and thousands of people who are insured by Blue Cross?
I'm not sure what they're going to do.
So it could be just for you, right?
It could be just for me.
You don't have any indication yet that anybody's working on network adequacy?
No.
Except maybe they're working on it for you personally.
Right. I think that might be, the only thing. And given the fact that, because I met with the woman who is the government relations person for Blue Cross Blue Shield about some other issues, and I talked a little bit about this, and she said, no, it's the provider's responsibility to let them know if their phone number is different, if they've moved, if they're no longer in network, blah, 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 blah. So there's obviously, in my opinion, a different view of the parity law from the insurance side versus the consumer side.
So you're in private practice as well, correct?
No, I just work for the Illinois Psychiatric Society. I don't practice law anymore.
All right. Then I'll pass on the other question.
Okay.
Thank you very much for being here today.
Thank you.
Representative Jimenez.
Thank you, Matt. Thank you, Madam Chair.
Your mic is not
on, but thank you, Madam Chair. Just a quick follow-up in terms of, there have been a lot of charges today by the first panel and the second panel with regard to the Department on Insurance. And there was an exchange on whether they were invited or not, but I do think that it's important that we get some response, either in a future committee or written, to the charges that have been made against the department, only because I think that it seems to me that we have state law and federal law that require some of these things that are being charged that they aren't doing. And I think at the very least, we need to get a response from them in terms of why they're behaving this way with different groups. So I'd appreciate that from the chair. But then to the panel, there's been a federal law on the books when it comes to parity for some time now. We've had the state law in the last couple of years. Have you had similar experience, if you've done this work with the state over the years, with prior administrations in terms of having these conversations?
You mean the federal administration or the states?
Yeah, just in terms of compliance, because there's been a federal law, and it seems like in part of House Bill 1, there were some strengthening as part of that law in the State Department. But I'm just trying to figure out in terms of where is the blame, and how do we get at that? Because it seems like we've been doing a lot of work in this area, creating laws, passing laws in the state, but it still isn't working.
Yeah, we don't need more laws. We need thoughtful and meaningful oversight. Where the blame, I mean, chronologically, the law was passed, the federal law, in 2008. We got interim final rules in 2011. We didn't get final rules till the end of 2013. So the plans kind of had this attitude that, well, we're not sure what we're going to have to comply with till we get federal rules, and they gave them a pass. And, you know, in fairness to insurance departments, they probably are understaffed as a general rule. They have a gazillion things to do, and the parity law is not something you pick up like a novel. It really takes some work to get at it. But in partly answer your question, the grant that was referred to before that Illinois got was a derivative of a White House task force, which was the last thing on parity that the Obama administration did. And they came up with these grants to do parity enforcement for exactly what we're talking about, that states needed help. They needed technical assistance to figure out how to better enforce and provide oversight for this law. So, you know, not that I like it, but in some ways we're in the beginning stages of what enforcement's really going to look like, and that states are actually doing it. But that doesn't mean there are still states that are dragging their feet. But the purpose of those grants was to up the game. So where's the blame? I think regulators have a job to make sure that the law is being complied with, and simply stated, that's more than a unilateral attestation that, yes, I always obey the speed limit, okay? So, you know, that's what it's worth.
I wanted to mention one thing. When I was, I just wanted to mention one thing. I did ask the chief of staff at IDOI if he was going to be at the hearing, and he said that they didn't know about the hearing, and that he was going to talk about it with Director Hammer and the general counsel. He never got back to me, but that's...
And when was that?
This was, I think, either last week or it was... maybe the week before Thanksgiving.
Thank you. Representative, I give you my word that the Department of Insurance will be very well aware, again, of the next hearing. I can't explain to you why they wouldn't feel it was important for them to be here today just because of the subject alone. I will also be sure that I give them a definition of parity in case there was any kind of communication misunderstanding going forwards. Representative Fine for a question.
Question and a comment. I think what's frustrating me the most today about hearing all these stories is when a family is in crisis, they don't want to start taking out their insurance book and looking through it. And there should be help available, and it shouldn't be as complicated. And, you know, Meryl's an expert, and she was having difficulties. So the person who doesn't understand what's going on, and I think that's kind of bears more burden on what the main issue is people get so intimidated by the entire process that they just give up. And that's a big concern, because what happens when you do give up? And my other concern is, you said the Medicaid rate for psychiatrists was set in 1996. Yeah, my junior in college was born that year, and prices have gone up on everything since. So my question is, again, you know, this is a very vulnerable population, but it's an illness that can be cured. And are we having more and more of a problem of psychiatrists accepting Medicaid patients? Because this is a huge issue on top of everything else with parity, with what we're seeing in the whole field.
We feel that this is a huge issue. Part of the problem with the Medicaid reimbursement rate is the rate hadn't changed since 1996, but there used to be these things called psychiatric leadership capacity grants. The last year that they were in effect, I think it was 2014, and then they were eliminated in 2015, they were $27 million for the state. And what the state would do is they would provide these grants to community mental health centers. And so what the community mental health centers did was they would take these funds, in addition to the minor reimbursement rates that they got from Medicaid, and that's how they would pay the psychiatrists. Well, the Governor Rauner eliminated the psychiatric leadership capacity grants, so that eliminated $27 million, and I can understand why the state wouldn't want to have to spend $27 million on its own, whereas with Medicaid, if you have the reimbursement rate, you get half, the state pays half, the federal government pays half. So in my view, the thing they should have done was increase the Medicaid reimbursement rate where they paid maybe $13.5 million, and then the federal government would have paid $13.5 million. So the state would have saved $13.5 million. But now what they've done is they've saved $27 million, but so many patients who are on Medicaid cannot access psychiatrists because of what's happened, because of the psychiatric leadership capacity grants that have been eliminated.
Do we know how many psychiatrists do see Medicaid patients in the state of Illinois compared to where they were when this grant was available?
We don't know. The thing that they would, when we obtained the information from, some information from HFS, the thing is that they have information regarding which psychiatrists are certified, but not which psychiatrists are accepting Medicaid patients. So there's a big difference between those two, because many psychiatrists get certified to accept Medicaid when they first come out of into practice, but then because of the reimbursement rates, they don't actually accept the Medicaid patients. So we really don't know the answer to that question.
The state could easily find out the answer to that question. I mean, you have managed care, you have managed Medicaid arrangements here, and counter data has to be filed. That information is available with some minor programming to figure it out. So the answer is discoverable.
Okay. And Dr. Nathan, I want to thank you for pointing out the number of doctors who also suffer from mental illness, because this, I think, is important in the conversation and in bringing sort of mental illness into the forefront, because it doesn't just happen to anybody, it can happen to everybody, and everybody's family is impacted by it. So thank you all for being here today.
Thank you.
And that is something that there could be legislation on.
Representative Anderson?
Thank you, Madam Chair, and that was a good segue, because that was actually what I was going to ask about. I was surprised to hear that there's this checkbox or question on the licensing form. Do you know, is that something that's mandated by an IDFPR rule, or is that something that we could address with legislation?
I don't exactly know why that question is on there. To be honest, one of my suspicions is a little bit of just institutional inertia. I think that, it's been on there for a long time, and until recently, physicians have assumed that maybe they shouldn't be ill and so forth, and so no one's really bothered. To expand it a little bit beyond that, it's really not just physicians. I mean, this applies to a lot of other professionals and specialties, and it's kind of why I highlight it as a stigma or parity issue. There's really, in terms of licensing anyone to do any sort of job, it's important for public safety, I understand, to make sure somebody has the capability to function in that role. But your medical history is not a relevant part of that, right? We need to know if you can do it, not whether you can or cannot.
Right. I guess my thought is that there used to be a time when commercial pilots, could not fly if they were on antidepressants. I believe that rule was changed. I know there was a time when the military basically put you on a watch list if you disclosed any sort of mental illness, and that has also changed. But we're still operating with the mentality, if you will, of check the box, and now you said every 3 months they have to go back for recertification?
I think if they answer yes to that check yes to that question for the first year, yes. After that, as long as everything's been okay for a year, they're allowed to practice.
Okay, and you said a number of states have done away with this?
Some states have, yeah. I don't have the study in front of me, but there's a recent study that compared. I don't know if they looked at. I think they looked at all 50 states, maybe including D.C., and compared states that had done away with that and some that still had that that in place. And
Do you know, is it the majority of states have it or don't have it?
it's about half.
Half and half?
Yeah, so it's still pretty
And I'm going to try to ask this in a very polite and delicate way, but I need to know the answer. So I agree with you that there's no real relevance to the question. Certainly, if a doctor is ill with heart disease, they may keel over and die, and that would be unfortunate, but would not hurt the patient. Similarly, if a doctor suffers from depression or anxiety, again, they may not show up to work, and the patient will move on. But there is one category that I could imagine pushback to such a bill, which is where you're answering the question that you might be a danger to others. Is there a way to tailor the question to limit it to that? So you don't have, I'm trying to be very respectful, but where there's not a risk of harm to others, because I could imagine that's where the pushback might come.
Yeah, I think that, the idea of being a harm to others is a state situation, not a trait, right? So it's not as if somebody's always that way, right? It's the product of a mental illness that can be treated. I suppose short of somebody just being somewhat evil and wanting to do harm, but it's not going to be found out by that question. So I don't think there's a real need even for that question.
Sure.
To the extent that if you're making it easier for a physician to access treatment when they do get into a crisis such as that, getting treatment may put them on temporary disability so they can get better and so forth. So those mechanisms, I think, are there in other places. The existence in the past or the present of a mental illness doesn't mean a person cannot function to perform their job. As a corollary to that, for example, anxiety is an incredibly common mental illness, people suffer from it all the time, but they get treatment and they function in their lives, and they may suffer, but they can still perform their jobs.
Sure, thank you. And thank you for also pointing out that the way we've got it set up right now is actually discouraging them from reporting and getting help. So clearly, it's an issue we have to address. Thank you. Thank you, Madam Chair.
Representative Wallace.
Thank you, Madam Chair. I'm going to thank this panel for their testimony as well. I'd like to go back to the point of the psychiatric leadership grants, specifically given the fact that the elimination of the issuance of those dollars has occurred within the context of us closing state facilities, closing other treatment available, whether it be community-based or not. And it also occurred within the midst of promises that were made to communities that lost those state agencies or other community-based services back in 2014. So there were promises made by the state to help them to recapture or to at least not let people fall completely through the cracks. And then in 2015, those dollars were taken away. Specifically in Winnebago County, where we have more opioid deaths or deaths related to opioid overdoses than the gun violence that we hear about on the news all the time. So I continued to fight and had $1.6 million placed into the budget for Rosecrans that has a triage center there that was specifically benefiting from those psychiatric leadership dollars. And this current administration specifically went through and refused to issue a contract that would allow for that triage center to operate, increasing those who are in our emergency rooms, increasing the time that it takes law enforcement to be able to respond to other calls, because if they've been called into the scene for a person who's having a psychiatric issue, they're taking them to the hospital and then they're staying with them at the hospital. So all of those resources have been removed while we have this administration going through the state saying it's going to do something to help our mental health crisis and our opioid crisis. But I wish that either of you, but specifically Ms. Sosa, since you brought it up, could speak to how those dollars help to mitigate the issues that we're talking about, the parity that you spoke of, Doctor, about pay. Can you speak to that issue?
Well, by having those those psychiatric leadership capacity grants, the psychiatrists were employed by the community mental health centers. And now they can only really hire them maybe part-time, if at all, because they just don't have the funds, because if they have to rely exclusively on the Medicaid reimbursement rates to pay for psychiatrists, it's just not enough. It's, and I know that maybe people think, oh, well, psychiatrists are doctors, so they make a huge amount of money. They don't, compared to other physicians. And so they have to earn a living too. And I was researching the issue since 1996. The cost of living for things has increased like 42%. And yet there's no increase in the reimbursement rates for psychiatrists. As I said, it could easily have a situation where instead of the state, I guess, you know, gaining 27 million, they could have gained just 13.5 million, and then, you know, change the reimbursement rate to relate to that, and that would have kept Medicaid patients able to see psychiatrists. Right now, the waiting time is really long. The other thing I wanted to mention is that emergency room care for psychiatric patients is the worst care possible for patients, because I've been to the emergency room at least 13 times with my daughter, and basically only one time did she get any help in the emergency room. The other times, she basically sat in a room. Often there was no TV or anything, so she's sitting there for 5 hours with doing absolutely nothing. And there's a security guard outside her door. So she can't go anywhere, she can't do anything, she has to just sit there. And meanwhile, in her head, all of the crisis is going on and she's not getting any help at all. And so and then some people don't get into, in the situation that I had last year, I had cancer and I had to get my insurance policy to cover North Shore Health System. And what happened was, because not many places covered North Shore Health System, I had to get a particular policy. And unfortunately, they had a carve out for mental health. And so I was covered at North Shore Health System. But then when I brought my daughter to the North Shore Health System for her inpatient care, I was told after the 5 hours of being in the emergency room, and she had been admitted to the inpatient unit, that she was not covered. That wasn't covered by the insurance policy. So on the one side, for my cancer, North Shore Health System was covered. For mental health, North Shore Health System was not covered. And so she was, the insurance company actually let her stay overnight one night at Highland Park Hospital, but then the next morning they took her by ambulance up to Vista West, which is an hour from my house. And she was there for about 9 days, and then they referred her to Rosecrans for rehab. And while we were at originally Rosecrans wasn't on their list, but there was no residential facility on their list, so they agreed to let her go to Rosecrans, but they only agreed to her being at Rosecrans and paid for it as if it was a partial hospitalization program, a day program, and I had to pay room and board for the residential stay. And then after 2 weeks, the insurance company decided, okay, you're done. And the standard for rehab is 28 days. It's just a total standard. And so after 2 weeks, they're like, okay, you're done. And so thank goodness Rosecrans had some kind of grant program, and they were able to let her stay for 2 more weeks on their side, on their payment side. So I've gone through like 2 different parity type of issues with my daughter, and it's very hard dealing with that with her.
I just want to apologize for my phone freezing in the middle of the alarm and not being able to turn it off. But I want to also thank you for sharing that, because we continue to talk about dollars and cents, and we don't realize what that is really doing to individuals and to their lives, and we can't quantify that. And I also think that, as you've mentioned, we actually end up costing ourselves more money as a state by not being proactive and not doing what we know needs to be done. So thank you for your testimony.
Thank you.
Okay, we are going to move on to the third panel. Thank you very much for everything. Really appreciate that. Oh, okay. Representative Feigenholt says, I'm sorry, do you guys mind waiting?
Just for the record, I just want to say that when we passed the budget, the money for psychiatric capacity leadership went back in, I believe till December 31st. The question, yeah, and I can get you that information, Merrill. The question is DHS spending it? So, but it did go back in. I mean, I think that we on the Democratic side put it in. So I'm happy to follow up on that with you.
Okay, thank you. I would appreciate that.
Neighbor, Indiana, has reported a 40% increase in just 2 years in the number of kids who are coming into Child Protective Services. And, you know, we've already seen DCFS testify in front of the Illinois General Assembly in October that calls to our hotline have been up 12% in the last 2 years after years and years of decline. So we know that Illinois we have not crested this crisis yet. It's on the rise still, and what we see just to the east of us is, you know, dramatically increased caseloads, and that's a problem because, you know, our system is not equipped to handle a 40% increase in the number of kids in care. And given that, we were very disappointed to see that DCFS was not part of the development of the Illinois Opioid Action Plan that was released in September. We also work with Redeploy Illinois providers across the state. These providers are serving youth who have been adjudicated delinquent and would otherwise be sentenced to the care of the Department of Juvenile Justice. Many of these young people have serious mental health and or substance use disorders, with researchers estimating between 50% and 75% of the young people involved in the justice system having diagnosed disorders. But successfully completing treatment for trauma, mental health, and addiction has been the key to the success of the Redeploy program over the last 10 years in reducing recidivism and keeping these kids from spiraling out into the adult correction system. Unfortunately, we've been talking to the providers across the state, and what we're finding is that they're having more and more difficulty accessing services for young people in the Redeploy program. And I'm talking about counties from, you know, really from end to end, from Winnebago County down to St. Clair County and all in between. These providers and also the prosecutors are reporting difficulty accessing treatment services, and that is exacerbated by the fact that most of these children are on Medicaid, and they have difficulty even finding sometimes even one Medicaid provider in the county. They frequently report having to travel to other counties in order to access care. One provider said to me, our major problem is figuring out what medical coverage people have and how to try to find services that match that provider. Another says, what can I possibly do with these children without any services to help them? A third notes waits of between 4 and 12 weeks in order to get kids even an assessment and get them into care. And unfortunately, with these kind of scattered, limited access to services, then you run into other problems that others have noted here, such as transportation, which quickly becomes a barrier too, and also limits providers' access to care. Especially if we are having parents take time off work to try to transport their kids to, you know, 2 or 3 counties away in order to access care. And then inpatient services are also scarce and becoming more difficult to access. For example, the Redeploy program in the 13th Circuit, which is in the middle of the state, notes that youth needing inpatient services have to travel to Rockford, Nashua, Chicago, or its suburbs in order to access care, and the distance from home can really limit the parents' ability to participate in inpatient treatment, which also limits the parents' or the child's success in making a difference. And then related to what some other folks have mentioned as far as reimbursement rates, Inadequate reimbursement rates also lead to very high turnover and some high staff turnover and inabilities to keep staff, adequately trained staff on board. And for young people, in order to make progress with your counselor, relationships are key. And for a young person to make a connection with a therapist or a counselor and then have that person be replaced in the next 6 months or so, what the adolescent sees is they don't say, oh, that's a reimbursement rate problem. They say, oh, here's another adult that's let me down. And then they become even more resistant to treatment. And it's like becomes a self-defeating spiral that makes it more and more difficult for us to help that child as he or she grows up. So, high staff turnover has been linked to worse outcomes in both the child welfare community and in other human services. So without going too much further here, I'll just say that I think we can do better to ensure that our most vulnerable children, youth, and families have equal access to mental health and addiction treatment services that they need to be safe and healthy and to be able to be on the path to a positive adulthood and give back to their communities. So I think ensuring certainly that Medicaid services are distributed around the state in a way that does not require people to travel 2 or 3 counties away is important. Having adequate reimbursement rates is also very important. And I think proactively incorporating DCFS and its contracted providers into the planning efforts and into the discussions with Medicaid managed care would be very important. To date, DCFS children are supposed to be folded into Medicaid managed care on July 1st, and there have been no conversations with the provider community yet. So that's very concerning. And finally, I would be remiss if I did not note that all of the plans that that our state has put together to try to address the mental health needs and addiction treatment needs of our residents in Illinois are all predicated on the assumption that the Affordable Care Act will be in place and that Medicaid will remain untouched and we'll have Medicaid expansion dollars. And, we keep operating under that assumption, and when I go to meetings, everybody assumes that that's the way it's going to be, but yet we see that these systems are under attack on the federal level constantly. And so I would urge Illinois to join its voice with the doctors and hospitals and human service providers and other advocates who are standing to fight to protect our care and improve access to mental health and addiction treatment services for families across our state. Thank you.
Representative Conroy, Representative Fine, Representative Anderson, Leader Lang, Leader Feigenholz, other members of the committee. Thank you for your commitment to practically address the pressing issues of mental health and substance use in Illinois. I know some of you have been champions of mental health treatment and mental health parity for decades. It's an issue we all know we can't ignore. My name is Terry Sullivan, and I'm Executive Director of the Alliance for Living, representing specialized mental health rehabilitation facilities, also known by its acronym of SMRFs. There are 21 licensed behavioral health treatment facilities now, offering longer stay psychiatric residential intervention for nearly 4,000 consumers with chronic mental illness, often with co-occurring substance use issues, and chronic medical conditions such as diabetes, COPD, CHF, conditions that many persons with chronic mental illness develop from either living on the streets or years of lack of medical care. As you're well aware, mental illness is not linear. There are periods of crisis, destabilization, and relapses with both internal and external triggers. SMRFs are the safety net for the community mental health system for consumers who need stabilization, stress reduction, symptom management, security, safety, socialization, and support during periods of destabilization and crisis. If you're in psychiatric crisis, the results in Illinois may be that you will wind up at the nearest emergency department or hospital if a bed is even available, which is why Illinois has the highest rate of emergency department utilization for psychiatric crisis in the country, where consumers in psychiatric crisis often wait 8 to 12 hours for a 15-minute psych consult with no counseling and no case management. The job is a person a danger to self or others, and if there is other psychiatric crisis, what's generally the result? Hospitalization. More than 90% of the Medicaid ER visits for psychiatric crisis result in hospitalization. Illinois also has the highest recidivism rate for psychiatric hospitalization within 30 days, nearly 40%. Main reason is no follow-up case management after discharge. Given a pamphlet or here's a phone number for our outpatient clinic, and I think we're all aware of the person in psychiatric crisis, if no one's going to contact them, they're not going to reach out. More often than not, they're back at the emergency department the following Friday. There are 25,000 hospitalizations for psychiatric reasons per year for Medicaid alone. That's excluding Medicare, insurance, and private pay. Just 25,000 for Medicaid alone. That's resulting in 160,000 Medicaid hospital patient days for psychiatric reasons, costing the Medicare system $100 million a year just for psychiatric hospitalization. It's an average of 6 days per hospitalization and an average of 430 Medicaid people every day in the hospital for psychiatric crisis. There is a more clinically effective and cost-efficient way to serving these consumers without using emergency departments, hospitalizations, nursing homes, or the criminal justice system to treat our citizens in psychiatric crisis. One possible model, which is in the SMRF Act of 2013, is a community triage center. It offers a cost-saving alternative to hospital emergency department utilization. As a community triage center, consumers receive immediate clinical attention from a psychiatric social worker and a psychiatric nurse, rather than waiting hours in a hospital ER or in a room with a guard on it. Intensive assessment and counseling and post-discharge follow-up linkage with a community mental health agency. It's all there in the package, all in less than 23 hours. There are 2 programs that we're well aware of, one of which is the Rosecrans Triage Program in Rockford that went on for 5 years, and there's a similar diversion project at Mount Sinai. They have reduced emergency utilization for psychiatric crisis by 90%, and that's over 5 years at Rosecrans, with a recidivism rate and a cost at less than half of the hospital ERs. Because they receive crisis intervention and counseling immediately, 70% of the clients return home in less than a day, rather than 90% being hospitalized. That's quite a difference. Of the other 30%, 20% went into a crisis stabilization center, 5% did need psychiatric hospitalization, 5% needed hospitalization for medical reasons. Very consistent figures at Rosecrans over a 5-year period. The second model is the Crisis Stabilization Center. The SMRF model of a Crisis Stabilization Center offers a community-based residential alternative to more costly psychiatric hospitalization. Consumers receive intensive treatment services for an average of 5 to 14 days with a maximum stay of 21 days. The model already exists in 17 other states at a cost savings averaging about half the cost of psychiatric hospitalization. A Wilder Research 2-year cost analysis contracted through the Minnesota Department of Human Services found that for every $1 of Medicaid funds invested in crisis stabilization centers resulted in $3.19 reduction in hospitalization costs. Pretty dramatic. The last model that is in the SMRF Act is the transitional living centers. This provides intensive community living and coping skills training for persons with serious mental illness who have been either institutionalized or have had chronic homelessness. These centers, with a maximum stay of 120 days, give consumers life skills like shopping, cooking, budgeting, basic housekeeping, getting around, basic self-medical care, medication self-management, goal-oriented recovery training, illness self-management, and coping mechanisms. What do you do when you start feeling edgy? Who do you call? What do you do? It's for successful community adjustment, moving from a lifestyle of dependence to a lifestyle of self-reliance. Many persons with serious mental illness living in the community end up in hospitals, jails, or nursing institutions, not only just because of the psychiatric crisis, but also because of poor community living skills, not being able to budget, not having a diet of a donut for breakfast and a McDonald's for lunch, and a ho-ho for dinner. I mean, they don't have these skills, and we've been working with people to make sure that they do develop these skills, so that it's not because of a lack of nutrition or lack of self-care that they end up back in the hospital. There's a similar program going on at Cook County Jail, particularly for inmates with mental illness, on exactly this kind of thing. How to cope with your mental illness, where to go for help, how do you budget, what do you do when you're beginning to feel in crisis to prevent recidivism and have a better transition into the community. In terms of barriers, despite a legislative mandate that the Department of Health Care and Family Services develop an authorization and reimbursement system for the 3 new services by the end of 2014, nothing has happened. The Medicaid managed care companies are currently operating in Illinois are familiar with these services in other states, and they're eager to have it up and running in Illinois. Rather than develop a separate state authorization system, the MCOs could efficiently provide the gatekeeping authorization as an agent of the state. From their experience in other states, the MCOs could also effectively negotiate rates for triage, crisis stabilization, and transitional living centers. Any support the House Committee could provide in encouraging the administration and the Department of Health Care and Family Services to move forward with a clinically effective and cost-saving alternative to emergency rooms, hospitalizations, nursing homes, and the criminal justice system would be greatly appreciated. Thank you.
Chairwoman Conroy, members of the committee, thank you for the opportunity to testify today. My name is Cherie Ariazola. I am the Director of Payer and Healthcare Strategy at Treatment Alternatives for Safe Communities, more commonly known as TASC. For over 40 years, TASC has been engaged in case management, designing and administering numerous programs that connect people involved in the court system, jails, and prisons with community-based drug treatment and recovery support services. We also work with juveniles involved in the court system and the IYCs, and also families involved with DCFS. I want to recognize the Kennedy Forum along with the co-authors of their recent report in elevating issues concerning access to behavioral health care and the good work of this committee. I also want to note that because approximately 50% of our court-involved clients and 75% of our reentry clients are enrolled in Medicaid, most of my comments today will be framed within Medicaid managed care, although a lot of the issues could easily be applied to private insurance. While there are multiple issues that impact access to behavioral health care, I just want to say that I resonated with all of the comments made today. In some shape or form, whether personally or professionally, every single comment that was made hit home for me. But the 2 issues that I want to speak on today are network adequacy and prior authorization. On the issue of network adequacy, as experienced by other providers and reported in the Kennedy Forum report, we TASC have been previously denied network participation by MCOs based on the rationale that there was no network need at the time. In HFS's 2018 model contract, there are provisions to ensure that MCOs contract with specific provider types. MCOs are required to contract with any willing and qualified community mental health center, FQHC, or rural health center. However, this contracting requirement is not extended to substance use providers. Further, it is important not only to ensure an adequate number of substance use providers within each network, but also an adequate number providing each level of care. A network may have an abundance of outpatient substance use treatment providers at its face or at its surface, but only one or two detox providers, providers that provide residential care, or even providers that incorporate MAT into their practice, which can contribute to outcomes such as people accessing services in the ER or out of network, as highlighted by the recently released Milliman report. To illustrate, we had a client in Jackson County who needed detox services and who was enrolled in an MCO. There were two detox providers in his area. He couldn't access services at either of them. One provider hadn't gone through the process of becoming a Medicaid provider, and the other didn't accept his MCO. When we looked up providers in his MCO's network directory, none appeared. When we asked the MCO about it, we were given the name of a detox provider 3.5 hours away. The client ended up accessing detox services as an ER admit. The second issue is impacting access is prior authorization. While we acknowledge and applaud the work of House Bill 1 to remove prior auth requirements for medication-assisted treatment, there are still prior auth requirements that exist for general substance use treatment. The MCO required response time to prior auth requests currently ranges from 10 to 14 days. If the request is marked urgent, this response is shortened to 1 to 3 days. While there have been discussions about reducing this time frame to 4 days in the 2018 MCO contract, this still remains too long to wait. Circumstances often warrant immediate access to care. Some MCOs have voluntarily taken upon themselves to remove all prior auth requests for behavioral health services, enacting their own policies that reflect the urgent need for timely access to treatment. When clients have just experienced an overdose or are otherwise ready to engage in treatment, but have to wait days or weeks for their insurance to authorize services, they may be forced to leave and come back once the insurer has authorized services, which we all know is not going to happen. When you have someone who is in need of services and ready to engage, you have a moment in time to do something, or they might end up in another system that can't turn them away, and that's the ER or the criminal justice system. Further, when providers accept clients into treatment while requests are pending, they face the risk that they may not be reimbursed at all if the request is subsequently denied. During the ongoing opioid crisis, prior auth requirements on addiction treatment, especially following an overdose or other crisis, defy common sense. They contradict the state's and the nation's recognition of an epidemic at play and impede the ability of people in need to get help when they need it. Given the current environment, addiction treatment should be presumed medically necessary. When people need help and there's a provider able to help them, the system should permit access on demand, not 1 to 14 days later. When someone is having chest pains and they do not have to wait days or weeks to get help right away to avoid a heart attack. So why aren't we doing the same thing to avoid an overdose? This barrier is especially important in law enforcement deflection programs that aim to link people to treatment rather than arresting and jailing them. Not only can it lead to missed opportunities, but it also places individuals at increased risk of relapse, overdose, hospitalizations, and even arrest and incarceration. That concludes my remarks. Thank you again for giving us the opportunity to testify today.
Don't see any questions, so thank you very much for your testimony. We're going to move on to the fourth panel. Sarah Howe, CEO, Illinois Association of Behavioral Health, and Samantha Olds-Frey, Executive Director, Illinois Association of Medicaid Health Plans.
Good afternoon. Thanks for having me. My name is Sarah Howe. I'm CEO of the Illinois Association for Behavioral Health, and thank you for taking the time for this hearing today. Much of what I had in my testimony was already said, so I will not repeat that, but I will pull out just a few highlights that have not been previously discussed. IABH works with MCOs, insurers, providers. We work with state agencies, and we work with yourself on issues of parity, as well as access, gaps in coverage, and capacity. So my comments here today are not just about parity, but about gaps in coverage and access to care. As Cherie just pointed out, one of the things that we often hear from our members is that they do have to wait multiple days to get authorization to get somebody into care. There are two things that happen here. Either they turn the person away and they say, keep calling, or we'll be working with your insurance provider and we'll let you know when you can come back, which is not a great answer. Or they will take them in and then oftentimes get denials 2 to 3 days later where they will not get paid for those days of service. Many times our providers will take them in because they are in crisis, whether that's a mental health or a substance use crisis. They don't want to turn them away. They know this is life-saving treatment. So they will do that and work with the insurance provider, whether that's private insurance or managed care. I'm not distinguishing between the two. But that is something that we see often, and what Cherie pointed out happens not just with TASC, but happens with our providers across the state. One of the things that has come up recently as the opioid crisis has escalated is a new wrinkle that is really concerning. Our members who have patients that are struggling with opioid detox, with opioid addiction, are being sent to a residential provider for opioid detox. And they either have, again, private insurance or managed care coverage. They assess them at a clinical level that they need opioid detox, which is American Society of Addiction Medicine level 3.7, and they assess them as medically necessary. They're being rejected because they are told that they would not die from outpatient detox. So let's think about that in terms of a general healthcare issue. If you would be told, well, you would not die, so we can put you in a lower level of care. That is happening regularly. We get these reports frequently from our members. This is very specific to the ongoing opioid crisis. And we do believe that is a violation of parity law. In other instances, we have had people, again, turned away just because they need, again, outpatient. They say, well, they haven't drank for a day or two, so they must have to go to outpatient. I had one provider that reported to me that they were told that their plan says that their plan likens, I shouldn't say says, likens residential treatment to an elective procedure similar to plastic surgery. And they were told that from one of the plans as they were trying to get approval for residential treatment. So we have several of these concerns that have come up because we've been tracking them for many years. We've been working on parity across our 50-year existence that we've been doing this. I do want to let you know that we are excited. There is a new project. It is called the Parity at 10 campaign. As David Lloyd pointed out earlier today, the federal parity law is 10 years old, and there is a national movement to have a new campaign to work on enforcement efforts. And Illinois has been identified as one of 5 states, and IABH is the anchor organization that will be working on this Parity at 10 campaign. We're going to be working very closely with our partners at Kennedy Forum, as well as several other associations. But the bottom line is we're going to be doing a strategic plan, and we're going to be developing what we believe should be legislation going forward. We have HB 68 already that we're working on. We may tweak it. We may do some other things. It'll be based on our strategic plan. So we will be coming back to this body letting you know once we pull that plan together. And we have the support of groups like the Legal Action Center, Kennedy Forum National that will be working on this. The last thing I want to say before I turn it over to Sam is not necessarily parity, but talking about access to care. And what we see oftentimes is whether you have Medicaid coverage or you have private insurance dictates what kind of coverage you can get. And on a very personal level, my sister, my older sister right now, is in a residential facility for very severe obsessive compulsive disorder. It's not something that I often talk about because she probably doesn't want me sharing all the details of her life. But what is very interesting is my sister has Medicaid coverage. Because of her severe nature and the very specific treatment that she needs, there is no coverage for this OCD. On the private side, if she had private coverage, she would be able to get that. But she does not work. She hasn't left the house in 5 years. She's under 100 pounds right now. She's 48 years old. So to get her into this very specific place, Medicaid won't cover it. So what happened was my father, my 82-year-old father, dipped into the savings that he had at $5,000 a week, and she is at this facility right now. My dad's out of money, and I'm going to probably bring her home this week after 5 weeks of treatment. And I have been told by the people, as I was driving up here for this hearing, I was told by her clinicians that she could benefit from longer treatment. but we're out of money. And my concern, this isn't necessarily, like I said, parity, but why is it because she's on Medicaid that she's not good enough to get treatment as somebody on private insurance? So there's inequities across the board. It's not just parity. It's gaps in coverage. It's capacity in the system. I will tell you from dealing with my sister's issue, there was only one place in the entire state that really focused specifically on obsessive compulsive disorder. The other one was in Wisconsin at twice the price. So again, we see consistently that we are not getting the level of coverage that we need, and that when we do deal with insurers, we're oftentimes finding some barriers that we really need to address. Thank you.
Thank you. Good afternoon. My name is Samantha Olds-Fry, and I'm the Executive Director of the Illinois Association of Medicaid Health Plans. I want to sincerely thank all of you for the opportunity to discuss this crucial issue this afternoon. The Illinois Association of Medicaid Health Plans represents the entire industry of health plans coordinating care for the Medicaid program in the state. While we do have some members that overlap and offer commercial or marketplace products, I do not represent those lines of business, nor do I have a full grasp and won't be able to answer any questions on that side. I really only focus on Medicaid. I do want to outline from our perspective what the Kennedy Forum of Illinois report outlined and demonstrated versus what it did not, and what steps have already been taken and what steps can be taken going forward to improve access and quality of care in Illinois. I don't think anybody who has taken even a cursory look at the mental health and behavioral health system in Illinois would say that it is adequate and that there is no work that needs to be done. And so we are really looking at this from that lens, that we all know that a lot of work and improvement needs to take place, especially as Sarah pointed out. From an access to care perspective, we do see a great divide between the resources that a Medicaid member has access to and the resources that somebody who would have private insurance has. And we see that every day, not only, though, from a mental health perspective, but from a specialist perspective across the board. The Kennedy Forum has done an amazing job at talking about the stigma associated with mental health, and I do believe that they are they've played a significant role in sort of decreasing that stigma. And the reason why we can all sit here today and have this discussion and so many people feel comfortable bringing up their personal stories is because in part of the work that they have done. And so I really want to applaud them for that. That being said, we do think this report has some severe and significant limitations, some of which that they point out themselves. One is, and I quote, "There is no guarantee that the sample of responding providers, which is significantly smaller than the population of all mental health and addiction providers in Illinois, represents all providers and experiences. Indeed, response rates differed significantly by type of provider." And why I bring that up is when we're talking about the Medicaid piece and we're talking about this report, the answer with the most responses regarding Medicaid was 66 providers. That doesn't mean that those 66 providers do not have, that their opinions aren't valid, that there aren't concerns, but that this report itself does not represent a statistically significant survey number, and that there was a significant divide, as they even point out, in what community behavioral health providers responded to versus hospitals versus addiction providers. And so I just want to make sure that we are taking a thorough look at what is actually happening and not just looking at a survey, a self-reported survey by, at most, on the Medicaid side, 66 providers. That being said, again, we do recognize there are provider issues, and one of which that we would take full credit for is that prior to roughly about a year ago, there was not a standardized billing process for Medicaid MCOs and behavioral health, or which I use sort of as the umbrella of substance use disorder or mental health providers. So each MCO, Medicaid MCO, had developed their own sort of billing process for these services, which was very complicated from a provider perspective, especially because those providers are going to be less familiar with Medicaid managed care organizations or with just insurance in general. Roughly 1 year ago, a standardized billing process was developed and has since been implemented. Since that implementation, we have seen a significant improvement of claims processing from health plans, from providers. There are still those issues from old claims that we are working through, and there still needs to be a lot of work of making sure that some of these smaller providers know about these billing requirements, that there is a standard process, because what we're seeing is sometimes they're billing the old way still, and so that's not being paid because there's a new way to do it. And so what we are doing from an association point of view is really trying to work with other trade associations to educate the providers across the state, both providers in existing managed care regions and in those regions where we know Medicaid managed care is coming. So this week alone, we have a meeting with the Smurfs. I believe next week we're meeting with all three trade associations representing sort of those community behavioral health providers. Those are initial, and those are just specific training on how to bill and interact with Medicaid managed care organizations. Those are the first steps. We suspect we'll have webinars going forward and other meetings based off of sort of the feedback we get from the provider communities. There will also be opportunities at those meetings for individual discussions, because what we see and what was sort of mentioned is individual providers have challenges with individual MCOs, and those things cannot always be fixed by legislative hearings or by legislation. Sometimes you just need to get two people in a room to understand, oh, you keep denying my claims because I'm not putting this correct modifier on there. Or from an MCO side, oh goodness, we looked into it and we programmed you wrong, and that is why all your claims have been, are having issues. Let's adjust that. We see things where we manually type in rates, and so if somebody's put in if there's a typo, it's in the system, that provider is going to get paid an incorrect amount until we sort of drill down and figure out what happened. And so those are going to just require individual discussions. So we're trying to create a format for those individual discussions to occur as well. And finally, we as a trade association have formed sort of a behavioral health task force or committee in which we are working with individual providers, trade associations, and the mental health professionals employed by every one of our plans, whether they be licensed clinical social workers, our psychologists, our psychiatrists, our pharmacy directors, and then also our care coordinators, which sometimes are RNs, to really talk about what do we see from a system as a whole that has shortcomings. Because again, parity is one issue, but when we were discussing the very low reimbursement rates for psychiatrists, I had a plan pull what are the reimbursement rates for our medical practitioners, and they're very low too. So we're looking at like $66 versus $69. So sure, increasing the rate, $3 would bring us to exact parity, but I don't suspect that $3 rate increase is really going to fix the problem. I think there are some other conversations that need to take place, and we want to have those conversations, and we'll have sort of those recommendations to you in short order. And there'll be recommendations not just from the plans, but from our community partners as well.
Representative Lang.
Thank you. First, Sarah. You talked about the ASAM criteria. Did we not, under House Bill 1, require that insurers use the ASAM criteria when they assess a request for service?
Not only that, but we required it's the only criteria that you use for substance use disorders. And if there is a dispute between the provider and the plan, according to ASAM, the burden of proof lies with the plan and not the provider.
And so I find it curious that that's going on, considering that's clearly in the law. Is nobody making a complaint to the Department of Insurance about this?
Depending on, it's either Department of Insurance or HFS if it's a private plan or a Medicaid MCO. By having worked with our providers, I know some of them have worked with the state agency. Whether they've made a formal parity complaint is a question I can't answer. I know we have recommended that's what they do.
Yeah, don't you think it's time that formal complaints be made rather than people
Absolutely.
just sitting around wringing their hands and saying, oh, woe is me? right?
Absolutely, absolutely.
Wouldn't that require the department to then react in one way or another?
Yes.
Well, not
They'd have to
necessarily, but
respond.
if they didn't react, then there would be a price to pay for that. For Sam, what is your reaction to this one point? Where are your insurers on the issue of using the ASAM requirements in these situations?
So this is the first I've heard this specific complaint. I hear plenty of complaints from providers. I've not heard of not utilizing that ASAM requirement. I know from our perspective, we sent out House Bill 1 at the time, we sent out analysis. We have had very clear discussions on the ASAM requirement, but I don't have specifics. Even, obviously I would never, and I don't want a specific of, including PHI, but I have not received a specific of health plan Z. We have a complaint around not following ASAM. So I have not heard that.
All right, so Sam, let's move beyond that for a second. You would acknowledge that there are parity issues, correct?
I would assume that there are parity issues. I think Medicaid, MCOs have are uniquely positioned. And that when we talk about parity, we have to not only look at parity from an MCO perspective, but also really the parity of the structure of the program itself. And I think when you look at Illinois Medicaid, that structure of the program is where you're going to see this most significant lack of parity, is actually the underlying fee-for-service program, from my perspective.
I'm not sure that answered my question. Would the folks you represent acknowledge that there are some issues with access to appropriate care and treatment, and that there are probably parity violations in some manner?
So I would say that there are access to care issues, especially around behavioral health, but those access to care issues exist on the fee-for-service Medicaid side as well. And they exist on the specialized, on specialties on the medical side too. And so I don't know that I would say, again, drill down and say that is a parity issue, but that is a real issue concerning members and concerning people and the quality of health care they're receiving. So nobody is saying there aren't access to care or quality to care issues. What I don't have the resources or enough insight to know is that a parity violation, or is that the Medicaid program in Illinois is not robust enough when it comes to providers and access.
Well, with all due respect, and we've known each other a long time, why don't you know?
From a trade association with two staff with a very complex, analyzing the parity of health plans would be a job that I and my other staff member could not do. Our parity is regulated by the Department of Healthcare and Family Services. We share more information with HFS on sort of any utilization requirement structure with HFS than anybody on the, on the commercial side. We are the most regulated sort of insurance product, so to speak. I suspect HFS has that, but I don't have enough resources to analyze the parity structure of every health plan that operates.
So I have to tell you, I'm baffled by your answer. I would have expected your answer to be, of course, Representative, there are parity violations, and we should do everything we can do to root them out. But that's not what you're saying.
No, it is not what I'm saying.
So you would say there are no parity violations?
No, I would say that I don't have information before me to say one way or another whether or not there are parity violations from Medicaid health plans.
If there are parity violations that are provable, what do you think we ought to do about that?
I think you should determine the root cause of them, whether it be that there is a current law in place not being followed, or if there are gaps in those laws. If there are current laws not being followed, they should be, those current laws should obviously be enforced. I also think that there is, again, a need to recognize that from a structural point in Medicaid, there are provider access issues. When we were talking about the specialized mental health, the SMRFs, there are 21. Almost all of them are in, the northern part of the state. And so when you look at that versus on an acute or medical side, you see providers more spaced out. And so the structure of how healthcare is delivered in Illinois and the Medicaid program has very clear access of care issues. And so you have to recognize, and it is recognized, that parity from a health plan perspective, Medicaid health plan perspective, is measured off of how different we are from Medicaid fee-for-service. So in a true, are we following the law, I think we are. What I don't think is happening is that we are delivering the care that members need, because that care doesn't exist today. Because when we have care coordinators calling to get those members into psychiatrists, and our care coordinators are hearing the same thing. We only take five Medicaid members a month, and those 5 spots are filled for the next 10 months. We hear that as well, and so we all agree there is a root problem in access to care for these members.
Do you expect to propose anything to fix that?
Yes.
For this coming spring session?
Yes.
Okay, thank you.
Sam, circling back a little bit to when you were talking about doctors' reimbursement, you said that there is, you see a 65, say, for the psychiatrist and 69 for...
It was like 66 something. This is very general. If there are modifiers, if it's different places of practice, those numbers all change.
Okay, so my concern about that, and my question for you is that when you're looking at that, are we comparing apples and oranges, or are we comparing apples and apples? Because a physician, their billable hours may be something very different than what a psychiatrist would bill. So we have a very big issue with having access to psychiatrists, because psychiatrists don't want to practice because they can't get reimbursed enough. So what I'm saying about that is that I think it's misleading. I think that when you look at what a psychiatrist bills and the fact that we're giving them $65 an hour, that's a huge issue, and it's a big barrier to access. It's also why we don't have psychiatrists available in a huge majority of our state.
No, and I would absolutely agree. What I would say, and why I say, but we have to be careful and not only focus this conversation on parity, is if we are also paying a dermatologist a very low rate, you may not have a parity violation, but what you really do have is an access to care violation. So we see access to care issues with psychiatrists and with many other specialists as well, because we pay such a low reimbursement rate that we are not encouraging them to either practice or to accept Medicaid members.
And so what do you see as the answer to that?
Well, I think a simple is more funding. And I mean, not only just from a Medicaid reimbursement rate, and so obviously we're going into budget negotiations. I feel like, they're just right around the corner. So the Medicaid program is crucial. But beyond that, a lot of providers utilize DHS grants to sort of stabilize funding that exists or doesn't exist from the Medicaid program. And so if we're really going to talk about improving the system as a whole, we need to see those funds stabilized.
And do you think that the last time this was reviewed, being 1996, is
a problem, significant problem? Yes, and not just for psychiatrists, for all specialists seeing Medicaid members. We see horrible access to especially any specialists that focus on pediatrics and on children. Dermatologists are some of the hardest to get access to, and they won't accept Medicaid, or they'll accept, again, like I say, 5 patients a month.
What I would point out is that we don't have people dying because they can't see a dermatologist.
But you actually do, if it's, it's skin cancer.
Not at epidemic proportions.
No,
like we have.
but if you have whatever it is, a threatening illness to your life, to the quality of life, and you can't see a necessary medical specialist, I think it is crucial. And so, whether it be a dermatologist or a psychiatrist, we have an access to care issue, and it really needs to be reviewed, and we need a robust solution, but that solution cannot just be 1 year or 2 years, because the second that you sort of have a destabilizing occurrence, you're going to go back to where you started.
Well, I would like to thank you for being here, since the Department of Insurance didn't feel it was an important topic to show up for. Representative Feigenholtz has a question as well.
Thank you, Madam Chairman and panel members. So, Samantha, I have a question for you. You made a comment about how your argument going from fee-for-service about managed care is, well, the fee-for-service side has problems too. And I would like to remind members of the committee that one of the reasons that we took the quantum leap of going from a fee-for-service system to managed care was because we were hopeful that the end result would be a health home and a patient-centered system. And the argument was that managed care has a lot more flexibility than being kind of tethered to a CPT code and not, and kind of creating a more flexible care plan that had, where you were able to put together a system that really was more recovery-oriented, especially when it came to behavioral health. And that's really what we were hoping for, and that you wouldn't. And so when you talk about FFS being just as bad, have you not, filed divorce papers for FFS? I mean, is managed care tracking some of that? And if you are, do you have to?
So there's a lot to unload there, so I'm going to start with some things. And first, it is that we are more patient-centered, we are more innovative than the fee-for-service system could ever be. Simple examples of that are, we brought in LCSWs and psychologists to serve Medicaid members well before the fee-for-service program did. We've worked with community mental health providers, behavioral health providers, supportive housing providers. I have several plans that pay every month for a crisis bed for their for some of these members. So we have done that. Where we struggle is on a few fronts. So first, fee-for-service is our baseline. That is how our rates are set. That is, how we began to partner with providers. It is sort of the, let's build some trust, let's build a relationship, let's start tracking data. It is almost always some either fee-for-service rate or some percentage of it, typically above fee-for-service. So that is where we start. There's also a process of encounters and why we need to, why we do mirror the fee-for-service system more than we at times would really like to. We've had a great meeting last week with the Department of Healthcare and Family Services to talk about what barriers do exist or are perceived from Medicaid health plans that are really stifling that innovation. And we're going to go back and present to them some information on why we believe we are stifled and figure out, is that just our perception or is that a real rule, and what can we address? So that is something that we are working on. Because I don't think anybody wants to just recreate the fee-for-service system.
Well, you know, I know that it takes a long time to get managed care up and running and get all the squeaks out, but I want to ask you another question. If I were to say to you, you have 12 months to prove to the state of Illinois and policymakers that managed care is going to work better, go and I would say go to a state where this is working well and figure out what needs to happen here to make it work, or else, where would you go?
What state would I go to?
Arizona?
Probably. I mean, Arizona would be on the list. I mean, I don't know what I could say right now. I could give you like the top 5 or 6 that come to mind, but I don't know. So Arizona, it works well. Michigan, it works well. New York and California have some unique models that have some parts that work really well, some that probably wouldn't translate. I can tell you where I wouldn't go. I would not go to Iowa. I mean, right now, sort of Iowa looks like is the poster child of what to do if you want Medicaid managed care to fail.
I just ask you because a lot of us have interests walking into our office talking about how this isn't working, and there's a tremendous amount of pressure on us. And so I just encourage you to try and fulfill the original promise and ask us if you need tools to help you get there. Because
I believe we will be coming to you with those asks.
So the other question I have is, you talk about money and rates, so we all know our rates are like really bad, which is what has put us in this situation, and I applaud you for your innovations around psychologists, LCSWs, hopefully soon APNs, et cetera.
We do panel APNs now. I don't know of any health plan that doesn't, but I don't believe that's something that we have the flexibility to do that I don't believe happens in the other.
Is some of this, you have an ability to pay providers more than our baseline. There is nothing statutorily that prohibits you from saying, you know what, we know that early intervention or first episode or finding housing and putting together a care plan, you know what works and what doesn't. And your hands are not tied. You can be creative and do this without us getting involved or HFS getting involved. Is that correct?
I would say that there are limitations to the statement you just made. So first, we do today pay above fee-for-service. I think a lot of you would be surprised that we often pay hospitals above fee-for-service in order to get them in network, because we cannot get network adequacy without paying sometimes 115, 120% of Medicaid. So when we're paying that to a hospital, we don't have those resources to potentially pay them to a community mental health provider. So there are limitations. Second, when we then submit our encounters, which is how our rates are set the following year, what we pay is repriced back to the fee-for-service rate. And so the resources that we get are assumed that we never pay over.
I would love to see data on this.
Yep, we'll get you sort of an explanation on sort of what that looks like. And again, we do believe that our hope is that the conversation that we started last week with HFS will talk about how sort of some of the practices in the past we believe fully inadvertently have sort of stifled some of this innovation and stifled sort of some of that investment in that preventative community-based care. Because it is all resource-based. Yes, we have the flexibility. In theory, we could pay everybody 300% at the Medicaid rate, but we're already operating at a loss in Illinois.
Is that because we're not paying you? I mean, if we were paying you.
So I think that's a great point. At various points of this last year, we as an industry were owed, I think the highest we got to was about $4 billion.
Yeah, no, I understand that. So here's.
When you pay us, we're also at a loss.
Okay, that's what I wanted to know. On time or not, budget or not, you have experienced a loss. Every single one of your members.
As a whole as an industry, maybe we have one member or two members who at times were willing or were able to not be at a loss. Again, we're not even talking about breaking even, we're talking about at a loss. But as an industry, our analysis from our independent, well-respected actuary says that, we are below sort of that break-even medical loss ratio. But what's more important, which just means that we don't have the resources to really invest to improve the system, to talk about how do we innovate to focus on members. I think that all of this should be, every conversation we have should really be, what does this mean for actual people, whether it's our rates, Medicaid managed care rates, or whether it's, Sarah's members' rates, or, parity law, all of that. It's such a sort of complicated, convoluted, numbers on a spreadsheet type of conversation, but at the end of the day, there are people and lives that are impacted by those numbers on a spreadsheet, and that's why we care.
Thank you.
Okay, it looks like we're done. Thank you very much. Thank you, everyone, for being here today. This was incredibly important information. There will be a second hearing scheduled, and as soon as I have that date, I'll make sure that people are aware of it.